People are generally very self-critical about themselves, and they have a sort of set idea in their head about the way they look. But I think it's always good to get a fresh set of eyes on you, especially from an aesthetic doctor. Because they look at faces all day long, they can sort of see what is really deficient with your features. Always just get advice before you go ahead and do something. An aesthetic doctor who just does exactly what you want, doesn't ask questions, doesn't advise you, is not the best.
I agree.
I think it's an important point as well, because sometimes knowing when not to treat is also as important as when to treat.
Completely.
Because sometimes, I say a lot of the time doing less is actually more. A lot of the time, you want to just kind of take it easy. If something looks good already, just leave it alone.
I would say the person holding the syringe is far more important than what's inside the syringe.
Yeah, for sure.
Yeah, I think most people would agree. And I'm possibly going to be a little bit controversial here, not to you, but to the viewers, and say, welcome back to Dr. House Podcast. Today we have a very unique episode. When a doctor's got a syringe in his hands, what's actually happening in his head before he puts the needle into your face for dermal fillers? It's not a question that is explored in a very great amount of detail or depth, but that's exactly what we're going to do today. I have a very well-known doctor in London, Dr. Arun Karwal, with me. We've got some videos of actual treatments in real time happening, and we're going to discuss what's actually happening. Why did the needle go in that place? Why was this instrument chosen? Why was this treatment plan made for that patient? It's a chance for you to see how dermal fillers are done in the person's head, not just visually as the needle goes into someone's face. What's behind the decision to do that? Arun, thank you very much for joining me.
Morning, Abs. Thank you so much for having me.
No, not at all. Not at all. I've been looking forward to this because you don't know this, but Arun is very famous in the UK because he's the doctor that smiles the least. And the more I call that out, the more we're going to see his smile today. So
I'll try my best.
So we'll go straight into it. We're going to start with this particular case here.
Right.
So this is someone a female patient that's come to you, I believe, for, was it cheek filler or tear trough filler or both?
Yeah, actually. So the funny thing is, actually, this is one of my trainees originally.
Okay.
For those guys who don't know, I'm actually a trainer at Dermal Medical. So this is one of my trainees, and I was teaching her cheek fillers, chin filler, and quite often the question comes up like, what would you do for me, pretty much? So I had a look at her face, and the main thing that I felt that was aging her mainly was her under eyes. And I think it's actually quite a common thing with a lot of people. If you just look around at the general public, most people, they have a bit of a hollow under their eyes, which tends to make them look tired, aged. So yeah, we agreed that, she can pop into my clinic and we'll address the under eye area.
Okay, fine. So I've got the video here on screen. I'm going to hit play. We've got a decent amount of time. It's like a 5-minute video. So we'll just play it, keep talking over it, and then we can rewind and go with that.
Cool.
So as I press play, you're drawing a line from the base of the nose, the ALA, to the part of the ear. Let me turn the volume down there. Yeah. What are you doing? Well, what's the point of that line?
So these lines, they're called Frankfurt planes, and they have a couple of roles. So firstly, they're to make sure that we are symmetrical, so that we're putting our injection points in a symmetrical way on the face. And the other role is that they keep us safe as well. So if you might be able to notice that these two lines, they make up 4 quadrants.
Yeah.
So they keep us safe from different arteries and veins on the face. Mm-hmm. So you'll notice in the sort of lower quadrant here, we've got the facial artery. In the sort of more medial quadrant, we've got the infraorbital artery.
Yeah.
And then this area you see on the cheek, generally we know it's a very avascular area. So it's quite a safe area where we can inject cheek
for those
filler.
who don't know, means less blood vessels. Yeah.
Exactly, yeah. So once I've drawn out the Frankfurt planes, I've got a sort of rough guide of where I want the cheek injections to go. Mm-hmm. And then now you just see me drawing out, I'm drawing out the orbital rim. So this is basically telling me if I go above that point.
Yeah, the rim of the eye
exactly,
socket.
Yeah. So I don't want to go right into the eyeball.
Yeah.
So it just keeps me safe from that as well. So here I am, now I'm basically revolumizing the cheek
Yeah.
And I think treating the anterior cheek, well, for those who don't know, anterior means front.
Yeah.
So I'm treating the anterior cheek usually in combination with the tear trough.
Yeah.
Because it just gives a much more kind of overall, more complete result.
Yeah.
So this is what I'm doing here.
So your needle there right now, and what we just saw, that was on the bone,
Yes.
and that was kind of trying to address both the cheek and the eye at the same time.
Exactly. Yeah.
And what we've got there now on screen, people are going to go, that's an absolutely enormous needle. But it's not a needle, is it?
Exactly, yeah. So it's called a cosmetic cannula.
Yeah.
So what it is it's a blunt tube that doesn't cut through any tissue. So it's not sharp like a needle. It just kind of wiggles around in that superficial fat compartment. And there's a couple of benefits. So one, there's much less swelling. Two, it's much safer as well because we're not able to perforate vessels. And three, we can easily sort of place that filler in a very even way.
Okay.
Into that tear trough.
like a knife spreading butter on a piece of toast almost.
Exactly, yeah.
Yeah. So what filler are you actually using in this particular instance? I can see it's got a slight blue plunger on it.
Probably guessed already. Yeah, so it's Teoxane Redensity 2.
Okay.
So this is the one I use pretty much all the time for tear troughs.
Okay.
The reason why, it's the least hydrophilic filler on the market.
Okay.
And it's particularly important here because the tear trough is very thin skin.
Okay.
We don't want a very hydrophilic filler which draws in water and at least puffiness.
Exactly.
And because I'm also putting fillers superficially under the skin,
Yeah.
it makes it extra important as well because anything that's close to the skin and it's hydrophilic, it will start to become puffy.
Fine. I mean, personally, when I do tear trough, I like to almost underfill on purpose.
Yeah.
So instead of making it look great on the day, I want it to look like it could still be volumized a little bit more.
Yeah.
I want to filter probably, let's say, 75, 80%. And then over time, it will probably reach 100% by itself as well. Are you quite similar in that aspect?
Fairly similar, yeah. I tend to push it a little bit more, probably like 90, 95%.
Yeah.
What I find really helps is that when we treat the cheek as well, because we're treating deep, so periosteal, underneath muscle, below the SMAS, we can achieve a lot of projection in that area. And it minimizes how much we need to actually place in the tear trough. And then, it minimizes the risk of that puffiness as well.
Sure.
But yeah, I totally agree.
So periosteal, for those that know, is another way of saying on the bone. It's in layman's terms. And the SMAS is a connective tissue layer in the face. And depending on whether your filler is placed above the SMAS or below the SMAS, you're going to get a particular type of projection or lack of projection in certain areas. So now I can see you've got the patient sat up.
Yeah.
Whereas before they were lying down. What's the thinking behind that?
Yeah, so pretty much whenever I'm pretty much always sitting patients up just to kind of see what's the result at that point. Because you can try this on yourself at home. If you just lie back and look at a mirror, it's like you've had a facelift.
Yeah.
So patients, when they come into my clinic, they're literally up, down, constantly throughout the treatment.
Yeah.
Because I'm lying them back to make them comfortable, do the treatment, and then getting them back up again and seeing how does all the tissue kind of drop down, how does the skin drape over the face.
Yeah.
And then we can correct from there.
Fine.
And then we got a better idea of what it's going to look like in real life.
Same.
Pretty much.
I mean, I'm especially when I'm marking up, I'll always try and mark up sitting up as well.
Exactly. Yes. Yeah.
And obviously the video's on a loop here, but when you were doing the cheek, I noticed you had a slightly different filler.
Yeah.
Which one are you using there?
So that one's a hard filler.
Okay.
So specifically, I use Intraline M4.
Okay.
And I use this because we want a filler that's got a good viscoelasticity.
Yeah.
So something that can resist force and keep its shape. Completely different from the one in the tear trough. We want something that's soft, that's not going to be visible when it's just under the skin. So using this very dense filler is going to be able to restore cheek volume and keep its shape because it's underneath quite a lot of layers of the face as well. So we need something that's hard and it's going to maintain that shape without, despite the patient being, smiling, moving.
Fine. So Aaron and I use different fillers. You're going to see different perspectives. Those of you who have watched, not many of you, who have watched my 5-hour monologue on dermal fillers, which is extremely detailed, you know that the filler I always recommend is Revan S. But Aaron's already mentioned 2 others. and they're perfectly fine. I would say the person holding the syringe is far more important than what's inside the syringe.
Yeah, for sure.
Yeah, I think most people would agree. So in this particular case, what else did you see on the face, if anything, that needed any kind of work? And we'll look at the before and after in a second.
I think in this case it was just tear trough filler.
Just that on its own.
Was it just tear trough filler? Yeah, I think it was just tear trough filler this time.
Okay. We've got Aaron's manager basically sat over here, making sure he doesn't say anything stupid.
But actually, I think it's an important point as well, because sometimes knowing when not to treat is also as important as when to treat.
Completely.
Because sometimes, I say a lot of the time, doing less is actually more.
Yeah.
And I think there's a lot of people, they go to clinics and they're just sort of, they get so many different ideas and treatments kind of like pushed onto them. And, there's a lot of kind of financial motive as well. But I think a lot of the time, you want to just kind of take it easy. And, if something looks good already, just leave it alone.
Yeah, I agree. So when someone comes to you for a tear trough problem, like in this particular case, in this case, we can see that you've treated the anterior cheek or the front cheek, let's say about here.
Yeah.
And then you've gone into the actual tear trough itself. What's your decision-making process for those watching who are sat there thinking, well, do I need both, like this video, or do I need just a tear trough itself? What makes you decide that?
Yeah, so I mean, there's a couple of things. So first, it's classifying what type of tear trough do you have.
Okay.
So is it a true tear trough? So with a true tear trough, this means that you've just got a hollowness in the tear trough. And it's quite a simple fix. In this case, we're just treating the tear trough directly with a soft filler.
Yeah.
On the other hand, if you've got something called a false tear trough, this in simple terms means that you've lost volume in your anterior cheek, so the front of your cheek, and on top of that, you've got some fat herniation or protrusion from your infraorbital fat compartment, so the under eye fat compartment.
Yeah, so the fat about here, you're saying that slipped forward because the support underneath has slipped down.
Exactly, yeah. And they will look completely different as well.
Yeah.
With a false tear trough, it's going to look more like a bag under your eye. So with that second false tear trough type, you have to treat the cheek with the tear trough. Okay. If you just treat the tear trough alone, you can actually end up making the tear trough look worse.
Yeah, because it looks overfilled compared to the hollow that's now underneath.
Exactly, yeah.
And I find also when there is a false tear trough, there is also quite a bit of a line here or a big depth here because the fat here has slipped down and folded over, and now you've got a big depth here as well as a bag here. And I think they're very commonly seen together. Do you find that in your practice as well?
For sure, yeah. And, adding to that, looking at the way that the face ages as well, typically most of the fat pads of our face, they tend to get smaller and they descend with gravity.
Yeah.
Annoyingly, that fat pad you're talking about, the nasolabial fat pad, is the only one that tends to grow on the face as you age. Yeah. So you end up getting really heavy here, which accentuates lines down here as well.
Downward, yeah.
Exactly. So you just end up with loads of shadows.
Now I'm going to pause the video here so we can see those cross lines that you've drawn from Hinder in 1975, if anyone's interested. Now, relative to where they cross, where are you aiming to put your needle?
Yeah, so one of them is exactly where all those lines are crossing.
Okay.
And that line is very predictable. You always see the sort of the deepest point of the cheek volume loss right in that point. So it's where the nose crosses with the tragus, 1 centimeter from orbital rim down to mouth corner, and then a line from the tear trough. It always seems to be there. The next one is just from your mid-papillary line, and 1 centimeter above that horizontal line. So those are, in most cases, where I'm putting all of the cheek injections when you need to revolumize the
when you want to get the projection from the cheek.
Exactly, yeah.
Fine. So once you've drawn these, what are you trying to draw on the face next? Because I know you're going to draw in the video, if we let it play, there's a few other things you're drawing afterwards.
What I generally draw next is, so marking out the orbital rim.
Okay, so the edge of the eye socket.
Exactly, yeah. So making sure I'm not actually going to get into anywhere dangerous. I also do draw out where the infraorbital artery is as well.
Yeah.
Because...
And where is that?
So generally I find it's always in the medial pupil.
Okay, so in line with the middle of the eye.
Yep.
Yeah.
Or your canine. So
Okay.
your canine and
Fang tooth.
exactly, yeah. So that pretty much, always is where the infraorbital artery is.
Yeah. And we can see you drawing there the white line, and I think you're
That's
drawing
it.
the edge of the eye socket
Exactly.
specifically there.
Exactly.
So it's a visual reminder that do not put the needle higher than this line.
Yeah.
Simple as that.
Yeah.
You're drawing out
or
safety
more medial
margins.
than this line.
Yeah. So you're going to draw that horizontal line on the edge of the eye socket and then a line vertically in the middle of the eye.
Yeah.
You don't want to go inside that line.
Yeah.
And you don't want to go above that line.
Exactly.
And that's where you're saying is safe.
That's it.
Now, I do things a little bit differently. What I tend to do, instead of drawing a mid-pupil line, I just use my ultrasound.
Okay, right. Well, that's gold standard.
Exactly. Yeah. So I will take my ultrasound, I'll find the actual infraorbital artery, do a little dot instead of a line in the middle of the eye, and I can go anywhere that dot isn't. That's the way I prefer to do it. But both are valid. And there's nothing wrong with that. Yeah. And I think patients will say, sorry, go on.
Yeah, no, I mean that's the next step for me, sort of, getting the ultrasound in and just sort of relying more on ultrasound guided injections.
Yeah. I think that's where things are going to go in the industry, and it's already started.
For sure.
A lot more people are doing it. I know a lot of people are reluctant to invest the money in it, but I think it's worth it for the knowledge and the relaxed evening that you have after clinic.
Exactly, yeah.
Patients won't know this, but whenever anyone places filler, like you or I or anyone else, there's always a little voice in our head. What if we didn't put it in the right place?
Exactly.
Because, why don't we talk about the risks? The risks of the dermal filler. I think everyone's seen horror stories. The worst case scenario is it's placed inside a blood vessel. That vessel is then blocked. Everything downstream no longer receives blood and therefore oxygen, etc. And I think the worst horror stories that people have seen and heard are because of this, right? This vascular occlusion.
Yeah.
And what kind of things do you as an injector do to minimize the risk of that happening?
I mean, it's a valid concern, and I have had vascular occlusions before. Luckily, all of them have been picked up like within seconds and reversed. And the patient has come back with no sort of complications and being able to have the treatment. So the things I would do to kind of minimize the risk. So first of all is, of course, injecting only in safe areas. So that's why we draw these markings to make sure we're away from arteries and veins. The other thing is we also inject in very small boluses at a time. Because
what's a bolus?
So a bolus is just when we're finding a point, injecting like a ball of filler into an area.
It's a technical term for ball, really, isn't it?
Exactly, yeah. So a little micro ball of filler. And so the benefit is that, let's say we actually are in a vessel. It's much better to cause a tiny occlusion with a micro bolus of filler rather than a big bolus of filler. And that's going to completely occlude that artery or vein.
Block it.
So, that's another reason. So we do small bolus of filler. And in some areas of the face, I also do aspirate as well. So typically with the bridge of the nose, I would say it's probably one of the highest risk areas on the whole face. I'll typically find the bone, and then whilst I'm staying very, very still, I'll aspirate on the syringe, so pull back on the plunger. And then that negative pressure should aspirate blood if we are in a vessel.
So aspirate means pulling, instead of injecting something into a location, pulling what's in the location into the syringe. So if you put a syringe into a mug of red liquid and you pull back on the plunger, when you pull back on that plunger, you should see red liquid start to fill up the syringe. So it's done in blood vessels to check, am I in a blood vessel? And that's essentially what you're saying, isn't it?
Exactly, yeah.
And I think that's all you can do to try and prevent occlusions. And I would also say, and you tell me whether you would agree, if a clinician causes a vascular occlusion, i.e. a blood vessel blockage, they could have taken all the safety precautions and done everything perfectly, and that still happened, right?
Exactly.
It's a bit like you're doing all the research on a company before you buy shares in that. Suddenly, unexpectedly, the CEO runs off with his secretary, the shares plunge. You didn't do anything wrong because you couldn't have predicted that.
Exactly.
And
Yeah.
it is a lottery. And I think you're right. I think drawing safety markings, being prepared to reverse and all these sorts of things, I think that's all you can do, and having a great understanding of anatomy, right?
Exactly, yeah. You stay away from all the major arteries and veins, but the truth is, the face is a massive web
It's
of
a minefield.
vessels. That's it, yeah.
Yeah.
So no matter what you do, you can still cause an occlusion.
Yeah.
But a safe practitioner will know how to manage an occlusion when it does occur.
And I think it's not about whether you get an occlusion or not. It's about, are you prepared for it when it happens?
That's it.
Like, for example, you've had vascular occlusions. I know you have, but it's never been an issue.
Yeah, exactly.
Because you've just recognized it and gone, okay, fine.
I've actually got one documented on Instagram as well. So I've actually filmed the whole thing.
Yeah,
so.
well, that's fantastic. I mean, a lot of people try to pretend they've never had one.
Yeah.
But it's great to see you do that, because it shows that if a patient wants to see you and they get it, they've got nothing to worry about. They just give you a message, hey, look, I think something's blocked. Can I come in?
Yeah.
Job done.
That's it. That's it.
A blood vessel blockage, I believe, is not a problem per se. It's a problem if you're left on your own and it's left to progress. If you notice a blood vessel blockage, what you need to have in place prior to treatment is an agreement with the person providing the treatment. What do I do if I suspect this has happened? And then if it does, you just carry out what you agreed, and then you're fine. As long as you're calm, you'll be fine. As long as you go to someone that can do it, isn't it right?
That's right, yeah.
And I think a lot of people don't realize, in order to dissolve it, you need the actual dissolving agent.
Yeah.
And you can only get that dissolving agent if you have a medical license like us to actually prescribe drugs.
Yeah, exactly.
And that's why if you go to someone not medically qualified, legally, they can't get a hold of that dissolver. And so I think it's not necessarily that there's greater risk, there's a greater inability to dissolve a vascular occlusion, at least in the UK, if you go to someone who is not medically qualified and therefore can't get that dissolver. So I think that's pretty much everything on this case. Why don't we take a look at the before and after and then see how it turned out. Let me just close that for a second. Was it this one?
That's
10?
the one, yeah.
Number 10. There we go.
Yeah. So you can see an improvement in the hollowness under the eyes.
Yeah.
Obviously, there's one thing that can't be really improved with dermal fillers, which is hyperpigmentation.
Yeah.
So you can do other treatments to further improve the eyes as well.
Yeah.
So you can try Sunakos, which is like a injectable skin booster.
I think everyone on this channel knows enough.
Oh yeah, of course. And then there's also if you don't want to have any more injectables, you can also try topical treatments as well.
Sure.
So there's like hydroquinone, extremely effective.
Yeah.
And also starting to introduce retinoids into your skincare as well can really improve that hyperpigmentation.
Yeah. So has this patient actually had any previous work done?
I don't think so.
Okay.
I don't think so.
Fine.
Yeah, pretty much.
So in terms of that under eye area, if the patient said to you, look, it's less hollow now, I think that's pretty obvious, but I want the texture of the skin to change. Is that something you refer for? Is that something you have a chat about at all?
Well, I mean, then it's more a chat about topical treatments.
Yeah.
So, if she wanted to improve skin texture, I would definitely start her on maybe retinol.
Yeah.
Like a retinol 0.1%.
Any particular brands that you personally go to for your patients?
Personally, I use Abaji.
Okay.
I think they're very, they're reputable.
Yeah.
They always sort of work very well for my patients.
Okay, cool.
Yeah. What about you?
I mean, for that, looking at that personally, I would have done things a little bit differently, actually, in this case. So I would have said to the patient, what bothers you first, as I'm sure you did, and that if the patient mentioned the texture, my personal preference actually would have been to treat the texture first.
Okay, right.
Because if I was to use something like a laser to do that, it's very difficult to do a laser after filler.
Right.
Because of the heat and the damage it causes that might affect the filler.
Right.
So my personal preference would have been skincare as well, to prepare the skin, and then do something like energy device to really resurface the skin.
Yeah.
With or without Sunakos before and after, if the budget is there. Once we've got the skin great, my personal belief and my clinical experience would be just doing that alone actually minimizes the look of volume loss. So on the left-hand side, we can see that hollow and that actual dip down. My view is when we see those on patients, those dips, that's not just because the volume underneath has gone. It's a combination of both volume that's gone and whatever loss of skin quality. Because if the volume's gone a little bit, but the skin is really loose and lax, it might exacerbate the appearance of volume loss. So if I get rid of that skin laxity first, if I start to smooth that out completely, I generally find the appearance of volume loss is much less. And I need a little bit less filler afterwards.
That's definitely a good option as well, sort of improving the skin quality first and then the filler, because also the filler kind of looks better as well when the skin quality is improved.
And you need less, so there's less risk as well.
Exactly.
However, she's got a brilliant result. I think that's taken a few years off, and she looks like she's had great sleep as a result.
For sure.
But for patients who are doing the filler first, I think I would do what you said. So we would look at things like the skincare. I would probably add in something along the lines of LED treatment as well. Completely non-invasive, doesn't even touch the skin. It's not going to interfere with the filler. I think that's probably another option that
definitely. And also, if you're on a budget as well, definitely good incorporating the skincare and the filler. It's not going to cost you a huge amount of money.
Relative to something like this. Especially if you look at the cost of like a big laser. You're talking 4 figures most of the time, aren't they?
Exactly.
So for something like this, what kind of price range, if you're happy to talk about that, what kind of price range would you look at for what we've seen on camera, i.e. the front cheek, the anterior cheek, the actual tear trough itself, the under eye hollow, and then maybe talk about what it would cost for someone to look at something like the retinol that you said as well.
Okay. So typically 2 mil tear trough treatments are 700.
Okay.
If it's just 1 mil, it's 450.
This is pounds, by the way, for the international viewers.
And I would say majority of people, they always do have some degree of anterior cheek volume loss as well.
Okay.
So I would say most of the time you're using 2 mils.
Okay.
Then with the topical treatments, you've got retinol. So you can pick up retinol for about £70.
That particular one that you mentioned, the Abaji one.
Abaji one.
Is it a cream? Is it a serum?
It's a cream. Yeah, so you can use it morning. With retinol, you want to generally start off only 2 days a week.
Okay.
And then if your skin is tolerating it, you can increase the number of days using it. And the other thing I mentioned,
work the same way.
And the other thing I mentioned was hydroquinone. So this is it's also a medical grade topical treatment. It mainly works on your melanocytes. So these are the skin cells that produce melanin. What it does is reduce their activity, and because they're not, these melanocytes won't be producing as much melanin. Naturally, the skin starts to lighten over time.
So if anyone's interested to look that up, hydroquinone is sometimes shortened to HQ if you're looking up scientific papers, and they're going to act on an enzyme called tyrosinase, and that is an enzyme that is used to produce the final product, melanin. So you're looking at, with everything thrown in, somewhere between, say, 700 and 900.
Yeah, something like that.
For all the injectables we've seen, for those topical skincare products that you said as well.
Yeah.
And this was all done in one session?
Yeah.
And in order to do the topical skincare as well and the hydroquinone with that, what kind of time frame are you looking to try and see a noticeable improvement with that particular brand that you like to use for your patients?
So I would say hydroquinone, in my experience, actually works really quick.
Okay.
I've seen clients have really noticeable difference in hyperpigmentation after about 8 to 10 uses.
Okay.
So this is like within a couple of weeks for some clients. Others takes a little bit longer, maybe 2 months or so.
Okay.
And then with retinol, I would say also about roughly a month, you'll start to see very good difference.
Okay.
One thing about retinol is that it can make your skin peel quite a lot.
Yeah.
So, some people find it a bit difficult to get used to at the beginning.
Yeah.
But, there's always use it with a good moisturizer as well to sort of maintain the moisture of your skin. And it will make that sort of redness and that peeling more manageable.
Okay. It's interesting to hear that, because I think the viewers of this channel are used to me saying very different things. It's nice to hear a different perspective and have that discussion. I mean, I personally, I don't tend to use retinol too much. What I tend to go for in terms of retinoids, which are vitamin A compounds, is more towards something like tretinoin.
Okay, yeah.
Because it's much more powerful.
Yeah.
But I think retinol for someone who wants something much cheaper, much more affordable, and is willing to accept slightly less result in the same amount of time, is a decent alternative.
Yeah, no, to be honest, I'd agree. I even use tretinoin myself.
Yeah.
But it's just that I find there's a lot of clients who have very sensitive skin. That's why I'm not always keen to give them something that strong.
Okay.
Because they'll come back to me saying, "Oh my God," they'll be panicking because of how red they are, how sore they are.
Yeah.
But if I can see that they're going to sort of be able to tolerate that quickly, fine, go for tretinoin. Yeah.
And then in terms of the moisturizer, again, I'm a very different-minded person, actually.
Yeah.
As I'm sure you probably know.
Yeah.
I pretty much never, ever recommend moisturizer to patients.
Right.
So I think it's nice for viewers to see how different people work.
I haven't actually watched that video yet, but what just remind me, why do you not recommend it?
The reason... the hyaluronic acid based. It's not that I necessarily say moisturizer bad. It's topical hyaluronic acid, and you find them in moisturizers. Now, the way hyaluronic acid is hydrating is the same way that, for example, lactic acid is hydrating. To be technical for a second, but I will translate. Essentially, what's happening is there is a certain element of, no pun intended, electronegativity that oxygen possesses, and this electronegativity forces the movement of the electrons between that and the hydrogen onto itself to ionize that, create a polyelectrolyte in the hyaluronic acid chain, which then attracts cations such as sodium and potassium, and then you get hydration spheres or solvation spheres or shells built up around them. And that's the source of the hydration. But the problem with hyaluronic acid is it's in the dermis, right? It's in the second layer of the skin, not the first layer, which is the epidermis. And when you look at natural hyaluronic acid in us under a microscope, let's say, in the dermis, it's a particular type in terms of molecular weight. That molecular weight cannot be rubbed on top and delved down. If it could, that means we have no skin barrier function. We'd probably be dead, because then toxins could probably get in as well. And that's why I never do it. Instead, I get nutrients to the cells because they produce their own hyaluronic acid, which is far better than anything we can rub in, because they've had 4.5 million years of practice, not a $50 million budget on a massive company. And so for that reason, I personally never recommend the HA products, and yet my patients never have dry skin.
Okay.
Now, I think there is a place for HA for people who want to reduce symptoms. For example, what you just said. If they mix their tretinoin and moisturizer, it might feel a little bit better on the skin, might reduce the symptoms temporarily. I get that. And there's a place for that. But is it actually having a physiological benefit? I think that's a different conversation.
Right. I see what you mean. So you suggest more sort of healing the skin from the inside out,
exactly,
rather than applying sort of like a bandage.
Yeah, instead of applying end products,
yeah,
which our cells make themselves anyway.
Right.
We put in starting products so they can make the end products instead.
Yeah.
And I also, if they do want a little bit of relief from tretinoin, one of the things I also like to use is squalane oil.
Okay.
Instead of moisturizer, because there's no hyaluronic acid in that. And if your hyaluronic acid doesn't penetrate into the skin, it sits higher, it's still, the chemistry is still the same, because there's still electronegative oxygen, which attracts a cation and then creates hydration and pulls in hydration. But because it's not penetrated, it still has to pull in the water from somewhere. So it could pull it from your skin, out of the dermis.
Squalene, I'll have to look into that one.
And that's why the day you forget to put moisturizer on, sometimes your skin feels dry.
Okay.
If your moisturizer was hydrating you all this time, why would it have left you dry?
Okay.
What I find is when I get people to drink water plus electrolytes, hint, hint, not pure water, and then they use an oil like squalane oil, not permanently, but at least to reduce symptoms, they're getting the hydration inside, and the oil is on top, so that water and oil don't mix, right? It's a polar and non-polar substance. They can't mix together. So the water doesn't evaporate out as easily, so it's trapped in.
Right.
So they retain the hydration.
Okay.
And that's the way I prefer to do it. But maybe give it a try. Let me know what you
yeah,
think,
yeah. I'll
mixing
look
it with
into
the squalane
these.
oil.
Yeah.
And the one I generally recommend is from The Ordinary. I think it's probably less than £10. And when I say that, they trust me very much straight away because they know I'm not selling anything and I just recommend something.
Right.
But then they can still get the tretinoin from me because you can't buy that commercially. It has to be prescribed.
Right. Yeah.
So yeah, let me know how that goes. Yeah. Did you prescribe any skincare for her in this case?
No, not this time.
Okay.
But
fine.
I gave her advice on what to use.
Okay. Cool.
Yeah.
Cool. So let's have a look at the next case. We'll go into this one, which is masculinization, I think.
Yeah.
So this particular patient, if we just wait for that to come up for a second, I believe it's a male patient. It's someone who is, I think, in their kind of 20s, 30s, something along those lines.
Yeah.
And you're going to be doing, I believe, the jawline and the cheek together.
Yeah. And the teardrop.
And a tear trough.
Yes.
So it's quite a big case. It's going to be really sharpening up those angles, going for that kind of almost male model type look.
Yeah. Exactly.
And I think even though it's a male patient, actually a lot of the principles that we're going to talk about, you apply to women as well, don't you? In feminization, as opposed to just masculinization.
Yeah.
So we'll play this. I think there's quite a good amount of time in this, so we'll just let it play and talk over it.
Sure. So this client actually originally came to me for just his under eyes. He just felt like his under eyes were looking really tired.
Yeah.
And then we also just got onto the topic of the jawline. So we ended up doing both. So pretty much I'm doing the same Frankfurt planes as I did with our last client you saw. So just drawing those on here. So they're used just to keep us safe from major vessels and also to keep us symmetrical.
And you've got a massive smile on your face under that mask as well.
Yeah.
But the one time you
it's
do
rare,
it, you
it's
can't
rare,
see
but
it.
sometimes you get them, yeah. So I'm just, what am I doing?
And that's all the filler in the background, right?
That's it, yeah.
That's all the intro
mounds
filler.
of filler there.
Yeah.
So this here, I'm just asking him to focus on this piece of gauze.
Okay.
It's just so that I can see the pupils in one spot and make sure I'm in the right.
So you know where the middle of the eye is.
Exactly, yeah.
Fine. And that's for your safety margin again.
Yeah, exactly. There's another smile there, actually.
It was. And when you get the middle of the eye, just to recap, that means you don't put the needle on the inside of that.
Yeah.
So you don't hit the infraorbital artery.
Exactly.
Or the infraorbital nerve, I guess.
That's right, yeah. Well, yeah, exactly, because they pass out of the same foramen, yeah.
Exactly. And now you've got the patient sat up.
Yeah.
And you're doing that, I believe, for...
So, yeah, now I'm pretty much just sort of... Now, at this point, I'm just judging what volumes each of these points are going to need.
Okay.
So it's just a very systematic approach. First, I'm finding the points, then I'm looking at what volume each of these points require.
Yeah.
So there's a lot of sort of like thinking at this point, and I make a lot of weird faces at my clients. I tell them, don't worry about my weird face, it's just me thinking.
So what are you doing here then? Now you're planning where to make the angle of the jaw, I'm guessing?
Yep, exactly.
Fine.
So I'm just feeling where his actual mandible is. Mandible is jaw.
Yeah.
And I tend to find for men, the cheekbone is quite in line with the jaw as well.
Yeah.
So it just kind of gives me that confirmation, this is the right point. You tend to find slightly different for women. They have the slightly more slanted cheek.
Cheeks are a little bit higher almost.
Exactly, yeah. And also the angle of their jaw
tends
to be a bit wider as well.
Okay.
Larger angle.
Yeah.
Men, it's a bit closer, so closer to like 90.
Okay.
That's typically a more masculine feature.
Yeah.
So here I'm just drawing them out.
And obviously one of the things you said is you're trying to see the relative amount of volume you need between left and right on the face.
Yeah.
So when you do the consultation, are you also giving them a rough idea how many mils it's going to be, or are you saying we'll only know on the day?
Yeah. So what I do is I give them a rough idea, and I always tend to kind of overestimate it slightly.
Yeah.
So I'll tell them 1 or 2 mils more than what I'm actually thinking.
Yeah. A lot of people
just so that when it comes to the end, and I tell them, actually I've used this much, and I've surprised them with a new price. I don't want to do that.
Yeah.
I'd rather give them a pleasant surprise and say, actually, I saved you a bit of money. I used a bit less.
Yeah. Yeah. I mean, I do that.
Yeah.
Because if you think something will need 3 mil and you do the 3, but it needs a tiny bit more, but you've got to open another syringe, I mean, you can't use that syringe for anyone else.
Yeah.
So you've wasted it, even if you only use a tiny drop.
Exactly.
So it's better to figure out how much you need and add a bit more.
That's it. Yeah. And for me, I always want to maintain that relationship with my client.
Sure.
If it requires a little bit more,
Yeah.
I won't be charging them more. I will just say, that's fine. It's on the house, pretty much.
Fine. And here you're putting the needle again deep onto the bone.
Deep onto the bone, yeah.
And what are you trying to project in this particular place?
Yeah, so I'm just trying to restore. There's volume loss at the front of the cheek, so I'm just trying to restore that volume. And also, one thing you might notice is my needle is pointed towards the medial canthus of the eye.
Yeah, it's going this way. Yeah.
Yeah, the reason I do that is because the filler, as it's coming out of the needle, it's going to track up. Basically, it's going to track along the infraorbital ligament.
Yeah.
So it's going to track up into where the hollow is originating from.
Yeah.
Another thing I do is as I'm hitting the bone, I'm
Yeah.
also tilting the needle downwards.
Yeah.
So that the bevel of the needle, so imagine the bevel of the needle is like this.
Yeah.
I want the filler to start pushing up towards the skin rather than come out like that.
Yeah, forward. Yeah. So now you've got a cannula on again, which is obviously much longer. It's not a needle, before anyone gets scared. And a lot of people, they see something like this, they see teardrop filler, and they think it just looks too scary. But actually, it's really not.
It's not. You know what? You know what's crazy? A lot of people, they actually fall asleep while I'm doing this treatment.
Yeah.
They don't feel anything.
Yeah. A lot of my patients will have a conversation as I'm doing it.
That's it,
even while I'm moving around there. And it is genuinely, if you don't like the look of this, the patient doesn't care. It's just a visual thing for that person who finds it scary. But actually, there's no needle there. You're not going to stab anything.
That's it.
There's no major nerves in that particular area to cause any kind of major sensitivity. I would say even vascular occlusion risk is not that high.
Yeah.
Considering, you've got a cannula and there's no huge major blood vessels like the facial artery in that particular place.
Exactly. Yeah.
So I think it's safe. I think it's comfortable. It just looks bad.
That's it. Yeah. It's just, I think people just get squeamish when you're doing anything close to the eye.
Sure.
But yeah, generally very, very comfortable and actually very safe as well.
Yeah. I mean, he doesn't look like he's in any pain.
That's it. Yeah. He's completely relaxed.
Yeah.
One thing is that infraorbital artery that's there.
Yeah.
It sounds like it's a very dangerous injection, but actually, if you were to put a needle into that spot,
it is protected a little bit as well.
Yeah, it's slightly protected as well. But the thing is, my point is, if you actually were to put a needle into that artery, your patient would be in excruciating pain straight away because of the nerve that's there as well.
Yeah. So the chances of occluding it are I don't want to say zero, but they're as close as you can probably get to zero.
Yeah.
Because before you even put the filler in, the patient's going to scream.
Exactly.
So you won't.
Exactly.
But then obviously if you hit the nerve, then the risk is possibly nerve damage, right?
Exactly.
So you still want to avoid it, and hence why you still did the safety marks, etc. Now you're moving this cannula back and forth and changing the angle.
Yeah.
Is that you trying to spread everything out as thin as possible?
That's right. So with the teardrop filler, you want to be constantly moving around. You'd never want any filler to stay in one spot.
Yeah.
So as soon as there's any pressure on the plunger, I'm moving. I'm never letting the syringe stay in one point.
So there's never a chance for filler to build in one spot.
That's it. Yeah. Yeah.
Everything is always liquid,
moving about like I'm playing a violin. Pretty much.
Fine. Yeah. I think I pretty much do the same thing.
Yeah.
Really, really, really tiny pressure.
Yeah.
So if anyone wants to watch the filler come out, it's a really slow trickle.
Yeah.
And it's constantly moving. So the amount that each area receives is it's almost nothing.
That's it. Yeah. So you do the sort of back and forth motion.
Yeah, I do.
Well?
I do.
Yeah.
Occasionally, I will actually use a needle in that area as well.
Okay. Right.
But the way I prefer to do it, I will have the patient lying back and use the flow of the filler, like you just said as well.
Yeah.
Sometimes I will even have the patient tilt away from me. So when the patient tilts away, the filler then flows even more into that area.
Right.
And the advantage of using a needle, I find, is you're actually going to be making sure that you're as deep as possible. With the cannula, you're hoping you're as deep as possible. And yes, I think it's definitely possible. You can do it.
Yeah.
But sometimes if you just pop through a layer into a different layer, up or down, you don't always notice.
Yeah.
And I think it's worth talking about the layers here, right? Because you've got the skin, and you've got the muscle straight down to muscle, and then the fat,
Yeah.
and then deep down onto the bone, pretty much.
Yeah.
And
yeah.
if you place it just under the skin, you're going to see that filler, right? It's a ball poking through the skin if you get it wrong.
Yeah, exactly. I mean, there's definitely different ways to do teardrop filler.
Absolutely.
I would say, I presume you put more of your filler deep into the soup, isn't it?
I think I can do. I don't mind doing it deep down.
Yeah.
The soup is a subocular oculi fat pad. So if you put it deep down into that fat pad close to the bone, but then there's a little bit that you can probably add on top under the skin.
Yeah.
I don't mind adding a little bit, but I really do mean a little bit, not much at all. What about yourself?
So I'm a bit different. Actually, I found that, over the years of doing teardrop filler, that soup can only hold a certain amount.
Yeah, I agree.
And after about 0.2 per side, there's really nowhere else for it to sort of go.
Yeah.
So once I've put a little bit down into the soup, the majority of it is just in the superficial fat.
Yeah.
In the superficial fat.
Yeah.
But the thing is, I'm not overfilling that superficial fat.
Yeah.
I'm still minimizing.
It's just going to look ridiculous, I think, if you
Exactly.
overfill the top fat.
That's it. I'm still always minimizing what goes into that compartment.
Yeah. And so now here you're going back to the jawline.
Right, yeah. So going back to the jawline
your fingers are trying to find the jaw angle and the muscle next to it, yeah?
Exactly.
The clenching muscle, the masseter.
That's it, yeah.
And what do you hope? Why are you looking for them? You've actually drawn a vertical line there.
Yeah.
That is the back of the jawbone.
Yeah.
And also where the clenching muscle edge is.
That's it, yeah.
Why are you looking for that?
So I'm finding the masseter muscle.
Yeah.
And I'm also finding the mandibular notch.
Yeah.
So in the mandibular notch, we've got the facial artery. So that's one of the main arteries that supplies the whole face.
Mm-hmm.
And that's a dangerous point to put a needle. So I'm marking it out straight away, and I'm making sure I'm not going to go anywhere near that point with the needle.
Sure.
We don't want to occlude that whatsoever.
Yeah. So here your needle is pretty close to the edge.
Yep.
Towards the bottom and back of the jaw.
That's it.
Where we want that projection, really.
Exactly.
Where we want that kind of shadow underneath to give that sort of model type look.
That's it. So now I'm creating that sharp angle to the jaw.
Yeah.
So I'm going periosteal. So that means I'm
Down
going right onto the bone. Mm-hmm. And I'm leaving those boluses, those balls of filler on the bone. And that's going to drop down the angle of the jaw and create the sharpness of the angle.
Yeah.
But I'm not going past that vertical point that we were talking about because of that vessel that's there.
Yeah.
I'm getting close to it, but not on it ever.
So you're happy to go towards the back of the jawbone, but not too far forward because of that facial artery.
That's it.
I think pretty much every injector would do the same for the same reason. I do it a little bit differently.
Okay. Hit me.
I just use my ultrasound.
Okay, right.
So I don't have to draw the front of that muscle edge. I just ultrasound it, look at the image, and I know exactly where it is. And that's it. I mean, some people, you're taught in anatomy textbooks, very reasonably, and this isn't a criticism, that facial artery, it crosses that jawline in front of the clenching muscle.
Yeah.
Mine crosses over the clenching muscle.
Okay, right. So you've ultrasounded yourself?
I have.
Yeah.
I have.
Okay.
And I've seen that in patients as well.
Right.
And so I think the anatomy textbooks, I think we both agree, they're an average.
Yeah.
It's never going to tell you the exact position on everyone.
Yeah.
But ultrasound has taught me the level of variation that exists. It's fascinating, and that's why I rely a lot on that now.
Yeah.
But if you don't have ultrasound, I think that's perfectly reasonable. And that's what probably the vast majority of people in the world do when they're injecting.
Yeah, definitely. Well, after you bought the ultrasound clinic, I was impressed with it. So that's probably the next purchase we'll make in clinic.
Cool. Yeah. So when you're doing it, I can see you've actually done a couple different injections.
Yeah.
The first one being sort of most furthest back towards the angle of the jaw, and a couple half centimeter or a centimeter in front of that. So you're trying to bring out that entire region, not just the actual point of the jaw angle.
That's it. Yeah.
So you want it to blend into the rest of the jaw, don't you?
Exactly. Yeah.
Fine. And what are you using filler-wise here? Is this inchline M4 again?
This is M4 again. Yeah.
Okay.
Yeah.
And do you ever use a cannula in this area?
I do, yeah. I think you will see a bit of cannula work as well.
Okay.
So I'll do a little bit of needle work to start with, just to kind of build that base and bring out the angle of the jaw.
Yeah.
And then, but the thing is, if we just use a needle there, it just creates too much sharpness there. and it just looks too unnatural, too protruding.
Yeah.
So then the cannula is used to blend that junction between the front of the jaw and the back of the jaw. So you've got a nice straight jawline
Yeah.
with the nice projection at the angle as well.
Yeah. If you just have a big projection on the angle, it just looks weird.
That's it. Yeah.
There's
Yeah.
a difference between a jaw angle and a jawline,
Definitely.
and everything together is what you need. And what are you looking for here?
So now I'm pretty much just looking, is it symmetrical? Does the other
Yeah.
side need a bit more projection from the angle?
And it's obviously set up for this as well.
Yeah, yeah.
It's much easier. And you're drawing some
Now-
more markings now. What are you drawing?
Right.
here?
So now I think what I've done is I've just measured out the length of my cannula.
Yeah.
For this area, I use a big cannula, so 70 millimeters. You can see there.
Very long. Yeah.
And pretty much that marking there is just the entry point. It's just so that I can see, am I going to be able to travel all the way to the back of the jaw with the cannula? And yeah, as you can see, it's reaching all the way to the back, and I'm jumping over that facial artery, that danger point.
Yeah.
The other benefit is that, the cannula, just like in the tear trough, it's going to allow me to put filler over a large area and
Yeah.
spread the filler over that large area.
So what you're trying to do then, by using a cannula here, you're trying to add a very, very small amount over where you did the needle work on the jaw angle, and the rest of it is moving away from that.
Yeah.
So that projection joins a projected jaw line,
Yeah.
essentially.
That's right. That's right.
And why do you prefer a cannula to do a line of filler like that instead of more injection points?
I mean, you can come along the jaw as well,
Yeah.
but it's just because of that facial artery there. I mean, you will still end up having that gap there. And I have tried to do jawline just with a needle, and it just looks a bit weird because you end up having that gap.
Okay.
So it just gives you that nice continuous line of filler along the whole angle. Yeah.
Smoothness, basically.
That's it. Yeah.
And I think that's a nice angle to see what's happening there. You can see the cannula almost the end of it where it's poking the skin, almost trying to get out.
That's it.
But that's not painful.
That's not painful, no, because it's basically in subcutaneous fat, so there's no actual
Fat just under the skin.
That's it, yeah. So there's no nerve endings in this part. So most of the time, people don't even feel what I'm doing.
Yeah.
They just feel a bit of sort of tugging in the area.
And it's a weird sensation, is what I've had it described to me as.
Yeah, I've heard it. I think generally people feel there's a bit of pressure, a bit of tugging, but it's not pain.
Yeah, strange.
Yeah.
Strange but not painful. That's a good angle there. So you're pressing the plunger and you're slowly pulling the syringe back to release filler in a line.
Exactly.
And you can see that, actually.
That's it. You can see the filler is basically taking the place of where the cannula was.
Exactly. It's leaving it behind. And I think it's important to also say one of the reasons the cannula is safer here, or one of the reasons people choose this, is because where the facial artery comes, which is as it comes up your neck and then it crosses your jawline, that crosses the bone, which means it's deep.
Yeah.
This cannula is not deep. So you can see it coming through the skin, it's more shallow, or what we call superficial, technical term for shallow.
That's it.
And so even if you're in the position of the facial artery, because you're in a layer above, you're not going to be injecting inside it.
That's it, yeah. And that same concept goes throughout all the injections on the face.
Yeah, of course.
Whenever we know that a vessel is superficial, we go deep.
Yeah.
Whenever we know that the vessel is deep, we go superficial.
Exactly.
So we're always constantly avoiding vessels.
And now you're switching to the nose here.
Yeah, so I thought, got a little bit of filler left over. Might as well create a little bit of straightness to the nose as well.
Mm-hmm. There's a very minor dips, isn't there? There's that smile.
Yeah.
There's a few very, very small dips.
Yeah.
Let's see how you do. And you've changed syringe here.
Yeah, so now I've gone over to an insulin syringe.
Yeah.
So it just find, the normal filler syringe is a bit bigger, it's a bit bulkier. I find this, you can just be that little bit more precise. It's just a smaller instrument, smaller needle, and also because there's a smaller diameter to the syringe as well. Mm-hmm. Each press of it is allowing a smaller amount of filler to come out. So there's small micro boluses, which as I mentioned before.
Yeah. So I think, people don't realize filler comes pre-made in a syringe.
Yeah.
And we add a needle to the syringe and then we can inject it.
Yes.
But what sometimes people do, including myself at times, is instead of injecting into the face, we inject into another syringe, which is much smaller.
Yes.
And because it's smaller, we have more control in our hand, just like this.
That's right. Yeah.
And when we say insulin syringe, that is literally an insulin syringe. The same. I mean, there's no such thing as an insulin syringe. There's syringes that are used for insulin because they're generic syringes, but that's what people in lay terms know it as, an insulin syringe. So a diabetic will use the same type of syringe to inject insulin to themselves. People use it for Botox as well, quite a lot too.
Yeah.
It's just a type of needle, a type of syringe that we have, and that's looking very straight.
Yeah. So just sort of augmented the tip of the nose here.
Yeah.
So previously it was kind of sitting lower down on the nose.
Yeah.
We put it into a more kind of cosmetically pleasing position.
Almost that ski slope that people say.
Yeah, exactly. Yeah. And, a lot of times clients come in and they always want a smaller nose.
Yeah.
I find non-surgically is quite a good way of doing it, because by lifting the tip up from down here to up here, we shorten the bridge, which automatically makes you look like you've got a smaller nose.
Yeah.
It's quite nice, even though we've actually added volume.
Yeah.
So yeah.
And now you're going back into the jawline here.
Yeah, so back into the jawline again.
Or maybe it was just edited in this way.
No, I work in a pretty random way. It's just I sort of go to this area, then I go to that area, and I'm just like, maybe there's a little bit of this, a little bit of that.
I think there's an advantage to that, because sometimes when you stop looking at an area, you do something else and then come back. It's almost like having fresh eyes.
Yeah, yeah.
And it's quite useful. And now you're back to the nose.
Also, it's the ADHD in me as well, to be honest. So it's like just painting a picture at the end of the day. That's how I see it.
Yeah.
You got the face and you are literally painting a canvas, but with different densities of fillers and different instruments.
It doesn't matter which part of the painting you do first, second or third.
Exactly. Whichever you feel like
painting at the end. Completely agree. I think personally there are some instances where it's better to do one thing before another, like a front cheek before tear trough, which I think we've seen before. But things that are unrelated, it doesn't really make a difference.
Yeah.
But look at that definition.
So you can see the sharp angle of the jaw now. The patient is super happy.
Yeah.
And he's also really happy because he doesn't look tired anymore.
Yeah. So he's had front cheek.
Yeah.
He's had a little bit of tear trough.
Yeah.
He's had his jawline. He's had nose.
Yeah.
Did he have chin, or you didn't do chin?
No chin. He actually had enough length. He had enough projection.
Okay.
So chin doesn't need anything.
Yeah. He's happy.
He's very happy.
That's what you call a smile, Aaron.
That's it. That's it.
That is a very interesting case. I think what's nice about that is it was not as simple as one particular area.
Yeah.
And people who come in asking for one particular area think they're going to do that one area and look fantastic. In a lot of cases, that's not the case.
Yeah.
Sometimes when you do one area, you look worse because that one area might improve, but it highlights how much worse the other areas are.
Yeah,
And I think this patient did the right thing to listen to you, to do everything, because you said they came in for tear trough.
Just tear trough, yeah.
Just tear trough.
Yeah.
And look at the result.
That's it. People are generally very self-critical about themselves, and they have a sort of set idea in their head about the way they look.
Yeah.
But I think it's always good to get a fresh set of eyes on you.
Yeah.
Especially from an aesthetic doctor. And they will kind of, because they look at faces all day long.
Yeah.
They can sort of see what is really deficient with your features.
Yeah.
And what's looking unbalanced.
Of course.
If always just get advice before you go ahead and do something. An aesthetic doctor who just does exactly what you want, doesn't ask questions, doesn't advise you, it's not the best.
I agree. And if someone suggests something else, it's not a sales tactic. It's because we've done it thousands and thousands of times, and we know how things turn out. Well, we have anyway. So we've got good experience. Let's have a look at some of the before and afters. We've got a few different angles. I'm going to look at the front angle first. Look at the difference in the eyes there. Wow.
Yeah.
He actually looks like his younger cousin.
Yeah, exactly.
That has better sleep. That's much better. Much better. And you can see that jaw angle as well. Even from the front, it's actually visible.
Yeah.
He's a little bit red, but I think that's just because needles have gone into the skin, obviously, isn't it?
Exactly. Yeah, you can see the cannula entry points on each side of the cheek as well there, yeah.
Yeah. That's good. Let's have a look at some of the other angles. So we've got this one here. That's a side. Look at that jawline definition. I think potentially, I'm going to say he could have a tiny bit more projection in the chin.
Yes, I think so.
The difficulty is it's hidden by hair slightly.
Yeah. And I think that's why a lot of guys actually have
I
beards
agree.
as well, is to give them the extra projection that
Yeah.
they're missing.
Yeah.
Yeah.
And I think some guys make the mistake of making their beard actually a little bit pointy in the middle.
Yeah.
That actually is a little bit more feminine.
It is. Yeah.
That width is more masculine, I think.
That's it, yeah. So for you guys at home, generally for more of a masculine chin, we will look at the mouth corners. So we want the chin to be about as wide as the mouth corner. For women, it's more the nostrils or the tubercles of the lip. So, and then there's also a difference in the shape. So men, of course, we want more of a square shape. For women, we want more rounded or sort of pointier. Yeah.
Yeah. And I guess he had the squarishness.
Yeah.
But looking at this angle, potentially, let's pretend we were going to do the chin. I personally suspect probably about one syringe should be enough.
Yeah.
To bring
Yeah.
that
No
forward.
more than 1 mil here. Definitely.
Yeah,
Definitely.
and that should be okay. The tear trough looks very different. Look at the size of the shadow. It's gone down his face quite a lot on the before, but it's stopped much higher in the after because of the projection coming forward now.
Do you mean the nose or the chin?
The shadow under the eye.
Oh, the shadow. Yeah,
Yeah.
exactly. And you can also see that, how much the cheek is coming forward now.
Yeah.
It's just sort of like blending into the whole area.
Exactly.
Do you have the other side as well? Or?
We do. But I just want to also mention on this angle the nose tip.
Yes.
It's almost looked like someone's pressed it in the before,
Yeah.
and now it's got a very, very natural shape.
Exactly. Yeah.
Looks nice. And we have another angle, which is that one, I think.
That's the one. I like this angle more, actually.
Yeah. Even look at that definition of the jaw. Awesome.
One thing I really I like to do with the nose, if you look at the nostril, generally the most pleasing point for the tip to be is where the nostrils are. So see, look at the line of the nostril. Tip should be about there.
Okay.
I think that's a good place to put it. How do you feel about that?
I try not to look at little rules like that, if I'm honest.
Okay.
I work differently. As I'm sure
There's no right answer with aesthetics.
No, that's true.
Everyone's got their
That's
own.
true.
Yeah.
What I generally tend to do is actually measure the interpupillary distance or the intercanthal distance,
Okay. Right.
and that gives me a number.
Right.
Everything on the face is then based on that number.
Okay.
And I'll go based on that. So I try and make everything as close to that particular ratio as possible. And
Is that phi ratio you're talking about?
to an extent,
Yeah.
to an extent. And what I tend to do is look at that distance. That gives me a proportion for the whole face.
Okay.
If that's tiny, that's never going to be massive because it's probably going to have a small head as well.
Right.
And so once I measure that, then I look at how close I can get everything into that particular calculation based on the intercanthal distance. The canthus, by the way, is that middle corner, that's medial canthus, and then the outer corner is lateral canthus. And the pupil, interpupillary distance between the pupils, which is on average, I think, in the human population around 62 millimeters, plus or minus 2 millimeters. So I will use those proportions and calculate it. So I try not to look at individual parts because if we say, for instance, let's take those lines that you drew before from Hinder 1975. Those lines are drawn based on particular landmarks. This point, this point, this point, and this point.
Yeah.
There's 4 points. But you're assuming those 4 are in the correct position to start with.
Yeah.
And my criticism of people teaching that, because it's not a problem of people doing it, because that's what they were taught. The problem lies with the teaching, I think. And the problem with teaching that is not explaining that that's only going to look decent if there's 4 points are in a decent place in the first place.
Yeah. True.
And if they were, things probably wouldn't need filler necessarily, or to the same extent. Obviously, there's aging.
Yeah.
And so then you have to ask, well, how do you know there's 4 points in the first place? And then you look on another landmark. Well, how do you know that one's in the right place? And you go backwards and backwards and backwards. And then you have this philosophical moment and you think, well, what's it all based on then? You have to start somewhere.
True.
And that's why I work here.
Right.
This is why I base it on that. Because even in this particular patient, let's say, for instance, he had massive nostrils and the top of the nostril was much higher.
Yeah.
You wouldn't put the tip up like this because then they just look really weird, right?
Yeah, I suppose.
And so I think there's an element that's missing in the industry of, well, thinking really, I mean, those cross lines that we talked about, I ask this question all the time. As soon as someone draws, okay, where's that from? No one can answer me. But the answer is Hinder in 1975, a German plastic surgeon. And the real reason that was done is to figure out where to place malar implants. And it wasn't where they crossed, it was in one of the quadrants. But we've almost bastardized that. And the original source has been lost over time. And it's just not taught. And so for me, I always want to go back to the source. I want to do all the research. I want to find out where everything is. I have every single page publicly available of Leonardo da Vinci's work. And when you look back at all these things, some of them stem from there.
Okay,
in fact.
right.
For example, if you were to look at someone straight on, the top of the ear here, and the bottom of the opposite corner of their face in terms of jaw angle from the front angle, that's a straight line, and it goes past the ala here and past the corner of the mouth here. Like
Yeah, it does.
That,
It does.
yeah.
Yeah.
That's from Da Vinci. And we've bastardized that into other things, and we've lost the original source. And so that's why I think very differently. I go to the original source, which I don't think many people do, unfortunately. So that's why I would do it slightly differently. However, in this case, I think it looks great because the edges of his nose are in the right place, I think.
Yeah.
Right.
Yeah, of course. There's going to be some clients who, no matter what you do, it's not quite going to. It's not going to give you the result that you're kind of looking for.
Yeah. You've always got to
it's
adapt.
always very general.
Exactly. And you've always got to individualize your thing. So even that rule that you just said of the tip being in line with that, I'm sure, I don't even need to ask, I'm sure if you had someone whose nostrils looked a bit different, you wouldn't necessarily follow that rule blindly. You would look at the whole face and think what looks better for their whole face.
Yeah.
But another thing I want to chat about here, it's a little bit tricky to see based on his hair, but I think potentially from this angle, a little bit of a dip in the forehead from the silhouette view.
Yeah.
But it is hard to see because of the hair in the way.
Yeah.
If it was me, I would actually consider a little bit of forehead filler.
Okay.
So that in the side profile view, the forehead skin, it doesn't dip in. It has a nice smooth, so from here, from the brows to the top, it's a nice smooth curve. Instead of a little bit wavy.
So this is where we're different. I mean, personally, I think that frontal ridge looks it looks masculine.
Yeah. Not the ridge. Not the ridge. So where the hair, the springy curly hair is.
Yeah.
So above that ridge here.
Yeah. So basically reducing this. So basically blending in this ridge here.
Blending the ridge into everything.
Yeah. That's fair enough. Yeah.
But again, there's no right or wrong.
Yeah.
And this is the thing. Like patients need to find a doctor who
shares the same aesthetic ideals as them. Yeah. Exactly.
Or someone who possibly even doesn't, but is willing to meet the patient's ideals in as safe a way as possible.
Yeah.
And that's perfectly okay.
Exactly.
And it's nice to see different perspectives.
That's it.
And realize there is no right or wrong. Yeah. And I think when patients go to one person, they have a consultation with a plan, and then they go somewhere else and they see someone with a different plan, they automatically, for some reason, they assume the first one was wrong because someone has done something different.
That's it.
Even, for example, when you go to a hospital and you get an x-ray and one doctor says this and you take it to someone else and another doctor says something different, they say, oh, the first one lied then. No, it's interpretation.
That's it.
There is an estimation. Like there's no right or wrong in a lot of things in medicine, actually, not just in the cosmetic side.
Yeah.
And so I think don't be put off if someone says something different to what you think or what another doctor thinks. As long as they're doing it safely, the beauty with fillers is, well, it's dissolvable, right?
Yeah.
Now, caveat, your face isn't going to be 100% the same, but you can dissolve fillers if you wish to. Should we look at the next case?
Yeah. Let's do it.
So I think the next one we're going to look at is this one, which is a nose of a female patient. Let me just bring this up 1 second. So there we go. So could you just tell us a little bit about this patient? It's a female patient, obviously relatively young.
Yeah. So this was pretty much like a full facial treatment, just to kind of accentuate the feminine features of the face. So once again, we're taking a very holistic approach, looking at different ratios of the face and seeing what we can do with each area.
Fine. And how old is she roughly?
She's mid-30s.
Mid-30s, okay. And you got a change of uniform as well?
Yes. So, okay, did I start with yeah? Okay, so it looks like I started with the nose here. I never, I always start with it.
That was mid.
Oh, was it mid? Okay, right, there we go. So it looks like we have done something so far. We've already done the under eyes.
Okay.
And we've moved on to the nose here.
Yeah, there's a little bit of redness around the cheek and the eye area.
That's it.
So I think there's something. It looks good actually.
I don't blame you for skipping it out because you see too much of under eye work. So, yeah. So pretty much, I'm
smiling.
I'm smiling, and I'm also just once again, like I said, I'm just trying to estimate where I think is going to be the best place for the tip.
Sure.
And with noses, I generally work from the bottom up.
Okay.
I know some people like to work more from the bridge downwards. I find that working from the bottom up, it allows the nose to get a nice lift from the bottom, and then it minimizes what I need to do at the top.
Fine.
And I think it's important because, changing the angle minimizes the work so that this is a more of a high risk area as well. I don't really want to put much filler here.
Fine.
So yeah, now I've kind of, I've drawn out a couple of parallel lines and I've also drawn a midline. The midline is important because it keeps us safe. We know that the midline of the nose is the most avascular as well, so the least vessels in the middle.
Yeah, because they're just off to the side, aren't they?
That's right, yeah. Now I'm creating a new tip also with the insulin syringe again.
So you're placing the syringe, you're placing the needle in the soft tissue, down onto the cartilage?
That's it, yeah. So onto the Cruz cartilage, basically. So there's two sort of heads of the Cruz cartilage.
Yeah, you can feel them in some patients, can't you?
Yeah. Some practitioners, they like to come from this way and bring the needle up, and it pokes through, pokes between the Cruz cartilages.
Yeah.
I prefer nowadays to balance on the Cruz cartilage.
On top.
That's it, yeah. And it just kind of, it creates more sharpness, more refinement to the tip of the nose, which I don't find that you can always get when you come between the Cruz cartilage.
Okay.
You get more of a rounded look. So that's what I'm doing here.
CRUS, if anyone wants to go and Google that. But again, I like the fact that you've changed from a filler syringe, which came in the box, to an insulin syringe or a Botox syringe.
Yeah.
Look at the control. Like, it's not a massive thing where you're stretching your hand out. Your hand is very, very comfortable.
That's it.
That's good to see.
Yeah.
And in that particular place on the bridge.
Yep. So this one, I'd say, is probably the highest risk injection you can do on the face, along with a sort of glabella filler, so forehead filler.
Yeah. And when you put your needle in, what are you feeling to know you've reached the right depth or layer?
Right. So here we're literally on the nasal bone.
So you're waiting, you're going in, something hard.
Yeah.
You stop there.
That's it.
And you're trying to leave the filler on the actual bone itself.
Exactly.
And I think another reason we do that is because the vessels are lateral, so off the midline, but also we have the SMAS, submuscular aponeurotic system. This connective tissue is sort of half, roughly in layman's terms, between the skin and the bone, halfway. The vessels we find are superficial to the SMAS, so above that, closer to the surface. So by going deep, even if there is a vessel on the midline somehow, maybe they've had surgery and things have moved around, we're still going to be underneath and not actually injecting it.
Exactly.
So that's looking much nicer, actually, already. Yeah. And you've not really injected a lot because that syringe, the insulin syringe, that's probably, what, a 0.3, a 0.5?
Yeah, that's the 0.5 I'm using there.
0.5, so the whole thing, if you were to inject it, is only 0.5 ml.
That's it, yeah.
And you've not even used a fraction of that.
Yeah, I think I've probably used about 0.2, 0.3 so far.
Okay, not a lot.
So this is, some clients, they worry that, I'm adding filler to the nose and they're going to look like they've got a bigger nose.
Yeah.
But you can see here that the amounts of filler I'm using, tiny,
very, very
tiny.
Small.
Yeah.
And this is you transferring the filler from the syringe in the box that the filler comes in.
That's it.
To the small Botox or insulin syringe.
Yeah. So we call it decanting the syringe.
And now you're going to put the original filler syringe back and get a plunger back into the insulin syringe. There we go. And now that's your new filler syringe, basically.
Exactly.
0.5 ml, but it's been barely filled. So you've probably got around, I'm going to guess, 0.2.
Yeah, something like that.
Something along those lines. And you might not even use all of it. Let's see. So you've probably got about 0.1 in there by the looks of it. So not a huge amount.
I think so, yeah. 0.1, 0.3, something like that.
Okay.
So I'm so because I've created a new tip and I'm also just building up the bridge.
Yeah.
after this, I likely will come down sort of to the middle of the nose now.
Yeah.
And slightly blend in that transition point between
From the
the
bridge
tip.
to the new tip.
Exactly.
Make it connect.
That's it, yeah.
And I want to point something else out as well to people watching. Look at your non-injecting hand. You're actually pinching either side of the nose.
Yeah.
I know why that is. Can you explain to the viewers why you're doing that?
Yeah, so it's basically to mold the filler and prevent leakage of the filler to either side of the nose. Because really, we just want it to sit right on the bridge in a nice straight line. We don't want it to leak down and basically widen your nose.
Yeah.
So that's the role of that.
So I think, if you imagine, for instance, if you've got a hill and you put something on top, you don't want it to roll down on the side. So if you put your fingers squeezing either side of the nose, when you put the filler in, the fingers are stopping it sliding down either side of the bridge and staying projected like a Christmas tree or something pointing up to the sky.
That's it, exactly.
So you're squeezing tight with your non-injecting hand to keep the filler on the midline.
Yeah.
Your injecting hand is going deep, 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 stop when you hit the bone.
That's it.
And you're injecting a very, very small amount. In each injection point, I'm going to guess you're probably doing maximum 0.05, something along those lines.
Yeah, exactly. Maximum 0.1.
Yeah. And I think that's not just to minimize complications like we spoke about before, but you just don't need a lot in the nose, right?
That's it. Yeah. Very, very tiny changes create massive results with the
Absolutely.
nose. Because it's the feature that kind of projects the most from the face.
Yeah.
Making tiny changes creates massive results.
Yeah. And also, you have something called a surface volume coefficient from one of the Sebastian Coetefana papers. I think it's Coetefana 2019. Certain parts of the face, if you inject the fixed volume across all those parts, some parts will project more, some parts will project less. It's to do with the depth
Yes.
of how much the filler is swallowed up by. There's no depth here, right? If anyone was to feel their nose, well, I'm sure you've done it at some point in your life, you can feel the bone straight away.
Yeah.
Whereas if you do it like here, you've got to press down to feel the bone a little bit. And because there's no distance really from skin to bone, a tiny bit will project the skin very easily.
Yeah.
Hence why we need tiny amounts.
And on the topic of that surface volume coefficient, sort of with the anterior cheek that you saw earlier, so you only see about 20 to 30% on the actual surface. So even though, I'm injecting about 0.5 mils, the difference you see on the surface, because it's so deep, is only about 0.1 or 0.2 mils. Yeah.
And the reason Aaron's able to say that, when he says what you can see on the surface, what he means is if you were to do a 3D scan of your face, you could measure the volume inside your head or inside your cheek or inside your nose, whatever, because you've got a 3D version. When you do filler and you do another 3D scan, and there are clinics that have these machines now, and when something is projected, it will actually calculate the difference in 3D volume. And that's how you know how much is projected by. So you saying you're injecting 0.5, but the projection is 0.2 mil, that's what you're referring to, right?
Exactly.
What the actual volume increase is visually.
That's it, yeah.
Let's have a look. So again, carrying on from here. So barely even saw the fillers inject, right?
That's it,
Tiny amount, that's all you need. And you can see automatically with a tiny amount, look how straight that is. That's brilliant. That beautiful smiling face. that's your default face. When I think Aaron, that's what I think.
This is the face you see most of the time. Okay, so here I'm coming to the saddles now.
So are you still going to be on bone here?
So now it's more cartilage.
Sure.
Sort of bouncing on cartilage. Being very, very gentle though, because you can actually perforate through the cartilage as well and end up inside the nose.
Yeah.
So as soon as I feel that slightly bouncy feeling, I'm in the right place and I'm starting to inject.
Yeah. Whereas in the bone, obviously, you're never really going to go through that. It's just going to bend the needle.
Exactly, yeah.
And your finger, I think, is just massaging very gently, yeah?
Yeah,
to push it in the right place. Look at that, beautiful. Tiny, tiny amounts. And it's made such a difference. And I think no. So you're trying to basically have a side profile view to make sure it's all as straight as possible while pulling your trousers up.
That's right. I'm making ugly faces. That's why I wear masks pretty much, because I'm trying to cover up the faces that I make during the treatment.
It's a running joke between us, as you can tell. But now you're adding a little bit more. And I see that you're not
Yeah.
decanting more filler into your syringe.
Yeah.
So you still only need tiny amounts.
That's
There's
it,
only a tiny amount
so
left.
really, at this point, I'm happy with the shape of the nose.
Yeah.
And I'm just looking sort of in a bird's eye view.
Yeah.
And seeing if the contours of the nose are nice and straight.
Okay.
At this point, I'm redrawing my parallel lines.
Yeah.
And I'm just seeing, is there anything further I can do to make the skin contour more even?
Okay.
And it will just be tiny little touch-ups.
Yeah.
Or tiny touch-up here, can make it a little bit sharper there.
Fine.
A little bit more refined here.
And you can see on camera here the markings on the syringe. You've got left in there just over 0.05.
Yeah.
So half of 0.1 mil. Tiny amount.
That's it.
And you're going from a vertical perspective.
Yep.
And you're injecting onto the tip. This is not where the bone is. This is where the cartilage is.
Yeah.
And are you trying to go, because you've got two pieces of cartilage here, and you can probably feel if you touch the tip of your nose, you can feel almost a gap between the two pieces of cartilage. It's like that, and your fingers rubbing over the edges. Are you trying to go in between the cartilage, or are you trying to go on top here?
Not in between. So I'm going on top here.
Sure.
That's it. Because I want the filler to actually sit onto something.
Yeah.
And project off something.
Yeah.
If I was to go through cartilage, you wouldn't get as much of that projection.
Agree. And your non-injecting hand is really squeezing quite hard.
Yes.
So you're trying to do the same thing.
That's it. Yeah. Same concept. I'm just trying to prevent any leakage because I want the filler to really just sit in that exact spot.
Yeah.
Nowhere else.
So if you put your fingers either side, it can't push out and
That's
stop
right.
projecting. It has to stay there, and it can only project up.
Exactly. Yeah.
Let's see how much you use. Wow,
Tiny bit, tiny
Probably
bit.
0.02
That's it. Yeah.
max.
And then I'm coming on the other side of the cruise cartilage.
Yeah.
Let's see. I'm going to probably
And again,
use- there we go.
0.02
tiny
max.
bit. Yeah.
Yeah.
And you just see it created that little bit more sharpness there.
And that's why you got to look so closely, right? Because you're working with such tiny volumes.
That's it.
And now you're going to do a little bit just above that. That's potentially on the bone, but a little bit off
Just
to the
to
side.
blend that
Yeah.
tip to the bridge.
Look at that. Nice. Brilliant. So I think overall, how much volume do you reckon you use on that nose?
I would say probably about 0.5 max.
0.5.
0.5, yeah.
That sounds about right to me.
Yeah.
And what kind of cost are we looking at for something along those lines?
So non-surgical rhinoplasty, 450.
450. Okay, cool. What kind of lifetime do you expect a patient to get from something along those lines?
So I'll say you should be able to get about a year and a half, sometimes up to about 2 years. And, even after that year and a half, 2 year point.
Yeah. It's not all gone, is it?
It's not all gone, no. You maintain most of the shape.
Yeah.
You might just need a little touch up, 0.1, 0.2
Yeah.
here. Because one thing I have to explain to clients as well is that as the hyaluronic acid is breaking down,
Yeah.
it also converts over to collagen as well.
Yeah.
Collagen lasts years and years and years.
Yeah.
So very long lasting overall.
I'll disagree again.
All right, yeah, you're the biochemistry expert, so I'm not even going to get into this one.
But I think I agree with you on the thing about it lasting a certain amount of time, but it's not all gone.
Right.
People, I think a lot of patients don't know this. And I see patients, especially in the lips, they think because it's been 6 months, I have to go and get more.
Yeah.
Absolute myth, right?
This is a myth, yeah.
Absolute myth. And I think what I generally say to patients, depending on how much I'm using and which part of the face we're treating, a bit of variation, but roughly speaking, I say, look, I'm going to do your treatment now. Total, this is what we're looking at for the initial treatment. Maintenance is something different. And both of them put together, I would suggest to maintain result, I probably want to see you to do this on average, everyone's different. Let's say something like 3 times over maybe 4 years.
Yeah.
And each time I'm doing less.
That's it.
The third time might be tiny, might be 1 syringe over lots of different parts of the face. And just a little bit of touch up.
To be honest with you, I see clients who've had lip fillers like 3 years ago.
Yeah.
And they've maintained most of the shape.
100%.
You probably heard about the study where they did the MRI scans of I think it was about 300 people's faces who had dermal fillers.
I know the people that did the study as well.
Oh, right. Okay. Yeah. Brilliant. So, the studies now are showing that fillers actually last like 10, 11 years.
Absolutely.
So it's completely different from what we initially believed, that, they only last a year and you have to have a top up. And we can see that in person as well.
Yeah, it just confirms what we see in day-to-day clinical practice.
That's it. Yeah.
And what people also don't realize is if you put X amount of filler in a face, after a certain number of years, it's 2X or 3X.
Yeah.
That's why we don't fill the tear trough completely. And we're not doing it because we're stingy. It's in your best interest. You don't want to fill the tear trough and then have the size go to 2X or 3X and just look like you've got a tennis ball stuck under your skin. Yeah. Anything else you want to add about this particular case still before we move to the before and after?
No, I think that's all good. Yeah, okay. So I mean, apart from the nose, here we did under eye, anterior cheek, nose, a little bit of jawline, a bit of chin.
Okay.
And I think we also did a bit of nasolabial lines here as well, I believe,
Let's have a look. So let me just get the before and after. It's these three, right?
That's it, yeah.
Let's have a look at them one after the other. So this is a side profile view. Jawline looks great.
Yeah.
Nose looks great.
And also you'll see that the nose, the lips and the chin are now aligned.
Yeah.
So we call it rickets plane. Generally, the most sort of beautiful profiles are when these three features are aligned in a straight line.
Rickets 1966.
Right, perfect.
I'm the nerdy one, as you can tell. So I think bringing everything into the right place, she almost looks, if you were to glance quickly, you could probably be forgiven for thinking, oh, they're sisters.
Yeah.
And it's not the same person.
Yeah.
And she's like the better looking sister now. Yeah. And I think if you look at the cheek as well, the way that is structured, there's no shadow underneath here, but you can tell it's stronger in the actual cheekbone.
Yeah.
And it looks much nicer.
Exactly.
And that nose tip, again, I think you brought it to the exactly, a fantastic position.
Thank you.
Because of the way it looks so in line with everything else in that lower face in this section here.
Yeah.
Jawline is good. Is there anything you would do differently in this case? Anything you would add or maybe take back?
I think potentially if I could see her for a follow-up, maybe a little bit more cheek contour.
Okay.
Yeah. What about you?
Which part? Well,
I would say, so not anterior cheek, but more lateral cheek contour.
Okay, so around here.
Yeah.
Yeah.
Just bring it out very slightly more. Not much, because one thing with cheek fillers, you have to be careful as well, because I think overdoing cheek fillers can actually age your face more than it does anything positive.
Yeah.
Because I find, especially with older clients as well, when they've started to have a bit of temple hollowing,
it doesn't look right, does it?
That's it. It actually exacerbates that temple hollowing.
Definitely.
When we've got sort of wide cheekbones.
Yeah. In this particular case, I think what I would do, I probably wouldn't do anything differently in terms of your treatment plan. I think I'd come to the same conclusion, but I would probably add to it and do a little bit more. If you look at the eyebrow, go from the eyebrow to where that skin meets the hair.
Yeah.
It's a straight line.
Yes.
I would probably have done a little bit in the bulk of the forehead, so it's a very smooth curve.
Yeah.
Because
I'd agree with you on this one.
Yeah?
Yeah. This one could...
Not a lot, not a huge amount. One
tiny
syringe,
bit.
Is more than enough.
Yeah.
More than enough.
Actually, one other thing could look nice is a tiny bit more of a brow lift as well. A little bit of a Botox brow lift to increase the arch of the brow.
I think lower brows generally are more masculine, as I'm sure we would agree, because of that brow ridge that's much stronger in men. The peak of the brow, I think, is pretty standard, pretty normal.
Yeah.
And about average of what you'd expect.
Yeah.
But you would just expect more of a sort of rounded and higher up brow, I think.
It would look quite nice,
Other than that, I think everything is very, very much in proportion.
Should we see the...
Let's have a look at some of the other angles.
Yeah, I like this one.
Look at the difference in the eye as well. She looks like she's well rested now.
Yeah, definitely.
I think that's brilliant. I think from this angle, in a few years' time, she may want a little bit here in the piriform fossa. I think at the minute it's fine, and I probably wouldn't say she needed it.
Yeah.
But I think that's probably in a few years' time where she will next
probably
want something done.
Yeah. That's another area where I have to kind of advise clients a bit as well, because you do have some clients who come and say, they want to remove this line completely.
Yeah. And it just looks weird, right?
It just looks weird, because I have to explain to them, even children have this line. So we don't want to get rid of it completely. That will look, that's when you start to get into the typical kind of pillow face, filler face.
Yeah.
So I think a little hint of this line is a good thing. It looks natural.
Let's have a look at the other one. Wow. I mean, we've not actually treated the color of the skin, but under the eye, it just looks so much brighter.
That's it.
Already.
Yeah.
I think when it's hollow, it's always going to be in shadow.
Yeah.
Just bringing it to the right level automatically it gets rid of it, right?
Exactly. Yeah.
She looks so much younger.
Yeah.
So much less tired, I think, under those eyes. And I think if you were to do, in this case, exactly what you just said here in the piriform fossa, I think that entire section here would look far too puffy.
I think so. Yeah.
And it just wouldn't look right. Looking at this angle, potentially, one other thing I would do. So we've got the nose here, that width, and then we've got the bridge.
Yeah.
I personally feel potentially the bridge is quite straight and then it goes suddenly into that nose width. I think potentially the bridge could be more triangular of a typical nose shape.
Yeah.
Unless that's just the lighting catching shadows either side, making it look narrower than it is. It's actually hard to tell in the photo.
Yeah.
But that's one thing I would just have a look at in person for me personally, but that's it really. Not a lot else. She was happy, I'm sure.
Of course, yeah.
Let's have a look at some others. So is there any particular one you want to go to? We've got a few here.
So we've done...
Well, you said temples can age you, right?
Yeah.
Why don't we have a look at that?
Yeah, let's have a look at that.
So this is a male patient that we've got here once we get it up on the screen.
Yeah, we've got James here. Okay.
So male patient, middle-aged, I think it's fair to say.
Yeah.
And you are, I think when the camera comes around, we will see you using a cannula, will we? Yeah. Yes, we will. So why did you choose to use a cannula instead of a needle in this case?
Yeah, so once again, it's just from, first of all, safety perspective. We've got the superficial temporal artery that comes around here. Very important vessel. Also, so the main thing is from a safety perspective, we don't want to occlude vessels. And then also with the temples, because it's quite a large area, the cannula really helps to spread that filler over a large area. So yeah, here you can see I'm pretty much, I'm in the superficial fat.
Yeah. Just under the skin.
That's right. And you haven't seen what I did at the beginning, but what I do is I insert the needle. Sometimes I do inject a little bit of local anesthetic there as well. So like a bit of lidocaine 1%, just to make it completely numb, because it can be sore. There's a lot of fascia in the area. After that, then before I start injecting anything, I'm actually just moving the cannula around in that superficial fat.
Without releasing filler?
Without releasing filler, yeah.
Just to make space, I'm guessing.
That's it. I'm just opening up a potential space. And then once it's opened up, then I can start to deposit the filler there. How do you feel? What would you do this?
Sometimes I've done that in the past.
Yeah.
I've done that in the past. I think it depends on the individual. But I completely get that. Because sometimes if you go under the skin, he's looking at himself in that.
Yeah.
So, to be fair, that shows how not painful it is.
Yeah.
He's actually doing a selfie while it's happening.
But he is a pretty brave guy. He's got a very high pain tolerance.
Nice. I think sometimes in the temple, the risk is if you just put the cannula under the skin and you do a few lines of filler that's released, when you finish and you look at it, you've got lines of filler.
Yeah.
Not a smooth spread over everywhere. And that's why if you go in and do the cannula moving first and just separate the skin from the initial layer, then the filler will just spread much more nicely. However, I do have to say that the cases in the past in my career where when I have had a little bit of a streak, it's never stayed that way. And it just massages itself out because we've got the temporalis muscle. So when we clench, we can feel here.
What kind of filler would you use here?
I would probably look at different fillers based on the layers.
Okay.
So as we know, there's multiple places you can place filler in the temple. What you're doing here, and even on the other side here, is the most superficial high up layer. You're just under the skin.
Yeah.
I believe, we both know there's that layer, and then there's deep as possible.
Yeah. So gunshot technique.
Yeah, we call it a gunshot. Not very well named.
Sounds pretty scary.
Yeah, but it's just a standard technique. Now, it's from the Arthur Swift paper. I've forgotten the name, the year, unfortunately. I'm going to get some hate for that in the comments. But that's where it's from. And I believe there's another area we can use. So we've got high up as possible, deep as possible. And then just below that high up, we've got the interfascial space as well, which I think is a little bit smoother because of what we got there.
Yeah.
So if I'm going deep down, I will look at something like Revanesse shape. The equivalent in the intraline range would be what you're using, the M4.
Actually, this one is M3.
M3, okay. Oh, as in, if we were going deep down. It would be
right,
M4.
yeah. So like gunshot, you would use something hard.
Yes, exactly.
Yeah, me too.
And then if I was using this technique just under the skin, I would probably look at something, depending on the depth, something along the lines of Revanesse Ultra or Outline, something like that.
Okay.
If I was going interfascial, again, probably something like Revanesse Outline.
Okay, right. Yeah. So you're looking more like mediums as well?
Yeah, roughly speaking.
Yeah.
And I think what we'll do, we'll have a look at the before and after of this, because I think that's quite interesting, so people understand why we do temples.
Yeah.
Because a lot of patients think, well, I don't care about my temples. Lips are what people look at, cheeks are what, cheeks, jawlines, that's that model look.
Yeah.
But like you said earlier in this episode, temples can age you, the hollowness. And if you do cheeks without looking at temples, you're going to make yourself look older. Right?
Exactly, yeah.
And I think what people need to study in the mirror is when you look straight as possible, the widest point in your face should be here, the maximum projection of the cheeks. From there, it tapers inwards a bit to the temples and inwards a bit to the jawline. Not going to get into technical details, but to some extent. And it's not necessarily the same taper. But if you have a certain taper to the temples, and then you extend the cheeks even more, you go here, now that taper looks bigger. That is what Aaron said earlier can age you. And I was standing from behind the patient. It looks like you're doing something to his head, like polishing it, but you're not doing that, are you?
So what I'm doing, I'm looking... you'll see me coming from bird's eye view quite a lot.
Yeah.
Especially when I'm looking at temples, even cheeks. When I'm doing anterior cheek, I'll look from above to see if they're balanced, and then especially chins.
Yeah.
So I look down always.
And I think that allows you to see the relative asymmetry and symmetry, right?
That's it, exactly.
For me, the difficulty with that is promising symmetry.
Yeah.
And I find, especially with a dental background, that this muscle, the temporalis here, as well as the clenching muscle master, 2 of the 4 muscles we use to chew. And if this is asymmetrical, or becomes asymmetrical as we age, and it can, based on the teeth, then it might make the face look slightly asymmetrical here. So I find older patients tend to need more on one side than the other.
Yeah.
Temple filler. Do you find similar?
Definitely. Not even temples. I would say pretty much every compartment. Yeah.
Agree.
And it not only from sort of like the dentition point, also from like
just
people,
aging.
Also the way people sleep as well.
Yeah.
I find that whenever they sleep on one side, that side is the one that tends to get more volume loss.
Yeah. And do you massage?
This? Definitely. Temples are the one area I always massage.
Okay.
And what I do is I kind of sweep upwards.
Yeah.
And what I do, the role of it is so that I can get rid of the blood in the veins.
Sure.
And once I've sort of massaged out the blood from the veins, I can see what is actually filler. Because whilst I'm doing that, the veins, they tend to get very irritated. They kind of get inflamed. And it's hard to see what is vein what is a streak of filler.
Yeah. Another one technique I use for this particular area, if I'm using that particular layer like you were using there, I'll put my cannula in as far as it's going to go. Before I've actually released the filler, beyond the end of the cannula, I'm actually going to put my thumb down. And then when I start to release filler, the thumb tracks as well, but not in a slide, in a like this motion. So my cannula is coming back and my thumb is doing this. Sliding. So it's massaged as soon as it's come out the cannula.
Yeah, it's a great technique. I've tried this before. Yeah, very good.
It works brilliantly, doesn't it? And you never ever, like when I'm finished, I'll massage as it's coming out, do it everywhere. And I pull the cannula out, I've got no massage to do.
Yeah.
You just can't see a streak or a line anywhere.
It's true.
And that's why, that's the point when I stopped actually putting the cannula in first and making space.
Yeah.
I just do that and I don't need it. Because I find also when I'm teaching, and obviously we both teach things like this, what I find is when people see that technique of opening up the space with the cannula, sometimes they're too aggressive. And they hit a blood vessel and they cause a hematoma, a massive swelling of blood. So I'm personally someone who prefers to teach that technique to more experienced injectors who want to learn something new. I try and keep it away from the new injectors, and I teach that instant massage post-release rather than the other one.
True. Yeah, so, for quite a newbie, having a massive hematoma like that,
it puts you off.
That's it. It can be disheartening for them. Yeah.
And now he's looking in the mirror and watching you do it at the same time. And interestingly, he's now sat upright as well.
Yeah.
I think personally for the temple, being flat or being sat upright doesn't make too much difference to the result. I think it's more just for comfort.
Yeah. It's me just sort of getting them up and seeing how do they look overall.
Yeah.
That's it.
Exactly. Same. Whereas I think if you're doing something like tear trough, lying down actually helps the movement of the filler.
Yeah.
And it does make a difference to the result.
True.
Whereas this, I think, is not necessarily the case. And how long have we got left on this one? It's finished. That's why it's not moving. So I want to see the before and after on this because I think it looks. I have seen this before. I think it's that one, right?
That's the one. Yeah. So this one, there's more than temple done here.
Yeah.
So you can see
what a difference.
Big difference in the mid face.
He's just got this brightness.
Yeah.
Because the light is catching his face now. It's not creating shadows everywhere.
Exactly.
And what I would like people to look at is the work Arun's done. If you look at the edge of the brow and then immediately to the side, you can see that there's like a cave in. Yeah. And now you don't see that.
That's it.
And we take that for granted when we're younger. I think. So always pay attention. And he looks so much younger.
Yeah. So apart from the temples, I mean, temples are only a small fraction of the work, but there's also forehead filler here.
Yeah, you can see the 11s lines.
That's it. Yeah,
that's gone down massively.
Also got anterior cheek. So there's quite a lot of volume in the anterior cheek there.
How many mils are we talking for this whole before and after?
This is around
probably
10, 12.
10 to 12
10,
mil.
12, yeah.
Yeah.
Actually, because, when this gent came in, he had such severe volume loss in the anterior cheek.
Yeah.
The first time I saw him, it was just the whole treatment was focused on that.
Right.
And actually, I got really excited, to be honest, because he came in and he told me, his under eyes are bothering him. And I already had like an amazing vision in my head for him. But then he said, okay, I think I'm going to go home and think about it. And I was like, oh, shit.
Yeah.
Then he called me about 10 minutes later. His wife said, get back there and have it done. So I came back and I was honestly so glad.
Yeah.
It was such an excellent result.
Not just us, but many people in our job, we would look at his before and think, oh, I can't wait to inject that. He's going to look so good. Like you just know certain people are going to look fantastic, right?
Yeah.
And you take so many. He's always trying holding back a smile. In the after, whereas he just looks miserable because he's so unhappy that his wife's told him off in the before. But that's a really good result. So, in terms of the cheek, just in this section alone, I suspect that alone is going to be 3 mil?
More.
Yeah.
This is about in the mid face. This is about 5 mils.
5 mil just in the mid face.
Yeah.
Wow. And I'm not even surprised. If you were to add any more, would you? And where?
So I would say, well, actually, I'm going to see this gent later on in the year.
Yeah.
So one thing I will get into soon is endo lift.
Yeah.
So another thing that does bother this client is neck. So he's got some laxity down here, a little bit of volume loss around the jawline. So we're going to do a bit of endo lift, start tightening up the structures in the neck and around the jawline.
It's like a radio frequency device for skin tightening.
Exactly. Yeah. So endo lift is it's like a fiber with a laser at the end.
Yeah.
It passes through the fat and it basically causes a bit of liposuction and it also tightens up the skin and soft tissues as well. So we're going to do a bit of that. And then one thing I will do in the future is to just start, after all these structures are tightened up, is start building a little bit more structure back into his jawline.
Yeah, sure. I think potentially even the transition from the chin to the jaw, because he's got a slight dip here.
Yes,
and I think it's quite common, to be fair. A lot of people have it.
Yeah.
And I think straightening that up would look pretty good as well. And I'm possibly going to be a little bit controversial here, not to you, but to the viewers, and say potentially a bit of lip filler.
Yeah. I did suggest it,
Okay.
but not too keen on it at the moment.
I thought so. But do you know what? More and more men are having them.
Oh yeah, for sure.
And it gives them a lot of age back.
Yeah.
Because you can see the lip now.
Definitely, yeah.
And that's a big thing. And I would say, don't be afraid. You know, you go to someone who has done it thousands of times, like either of us. We can do it like no one knows you've had lip filler.
That's it.
And
I think it's just like when you have very manly men.
Yeah.
They're not.
Just the thought of it,
Just
right?
the thought of lip filler is already putting them off.
Yeah, absolutely. And I think that so 10 to 12 mil total.
Yeah.
What time period are we talking? Was that one session?
So this was over 2.
Okay.
So the first session was mid-face, under eyes,
Yeah.
and I think nasolabial lines.
Okay.
Second session was temples, and also you might just notice labiomental crease as well.
Which is this one here.
Yeah.
Yeah. 2 sessions. That's pretty good.
Yeah.
That's pretty good. And then what kind of cost are we talking for something along these lines?
So this, looking about 3,000 for this.
3,000.
So
to
10
be
mils,
fair, for 10 to 12 mils,
Yeah.
for that kind of result, I mean, that's pretty decent.
Yeah.
You know, you're spending probably more than that for multiple sessions of lasers and skincare and all these things.
Exactly, yeah.
And actually, you do things in 2 sessions, instantaneous at the end of both those sessions to see the result, isn't it?
Exactly, yeah.
What would you do to further improve the result here? In terms of non-filler,
Non-filler.
if anything.
So one thing this client does come back for is just regular Botox.
Okay.
Just to maintain the sort of forehead area.
Yeah.
Of course, medical grade skincare.
Yeah.
I do want to start him on like a retinoid.
Yeah.
And then, like I said, we're gonna start getting into a little bit more energy devices, Endolift to start with.
Yeah.
That's it. That's about it, really.
Sure. I think potentially, I would.
What would you do? Sorry.
What would I do? Skincare I would go for as well.
Yeah.
Go for something like that. I would probably also look at some kind of, if you're worried about this, I would look at some kind of coring laser, like an ultra clear.
All right. Yeah.
I don't know if you've heard of those ones.
Yeah.
And that's probably going to be really, really good.
Cold laser or something.
Ultra clear.
Ultra clear. Yeah.
Yeah. So basically, you're taking a corkscrew into the skin, pulling out a column of skin, and then it just squeezes everything together.
Yeah.
So you're shrinking the face essentially without doing a facelift. I'll probably look at something like that. I think the skin looks a little bit worn as well, without wishing to sound disrespectful, but I think it does. I would look at something along the lines of microneedling. I would instigate home care in terms of microneedling alongside skincare like tretinoin as well. And I would also bring in regular LED treatment again at home, so we can do it much more often and go from there. And I would also inject quite a lot of Sunacos around the eyes. I think that the last remaining texture under the eyes, I think can go pretty easily with the Sunacos.
Yeah.
And I think potentially around the mid-face, so around here, a little bit more room, I think, for some filler.
Yeah.
If you look on the right of the picture, around here, there's still a dent.
Yeah. That's one thing I did struggle with actually, because with this client, it did have quite a prominent malar bag at the beginning.
You can
the
see
malar
it.
area is quite prominent. So even after doing the deep periosteal injections, it was still not quite there.
Okay.
So I did something a little bit off-label, kind of came superficially with the dense filler. And just deposited a little bit just below the malar area. That really helped because obviously, talking about sort of the, how much of the filler you can see, like this, what do you call it? The surface.
Surface volume coefficient.
Yeah, surface volume coefficient. Bringing the dense filler more superficially is better use of it, even though it's not particularly the safest. But aspirating and getting the filler into that part there, you get more bang for your buck.
So that's essentially what surface volume coefficient is, bang for your buck.
That's it.
If you inject a certain amount of filler, how much projection are you going to see? And that's what it means. Places like this, a very small distance from skin to the bone is going to be very high because it will project very quickly, places like the lip, etc. Deep in the temple, you've got to inject a lot to see any visual difference on the surface. And that's what SVC measures, which is different to everyone, but we have a rough guide for the face as a whole. Other than that, I don't think there's a huge amount I would do personally. I think he looks fantastic. I just look at personal preferences beyond that.
Yeah.
Not a whole lot else. That's a really, really phenomenal case.
Cheers.
When he comes back later in the year, what's your plan for him then?
So yeah, first thing on the cards, endolift. He's already happy.
Oh, so he's going to sign up for that.
Yeah, yeah. He's ready for it. We should have it around January.
So you've already...
We're in the process. We're in the
deposit
process.
down.
We're not that far, but
okay.
we're. I mean, I wanted the device for a while, but
I know. I've tried to convince you against it.
Yeah,
many
exactly. But priority this year was kind of getting the clinic up and running, and that's come with its own challenges.
Yeah.
So 1 year later, I think we're finally in the position where I can get back on that train with endolift.
Fine. So there's no other picture of that case, is there? No.
No.
So let's look at the male nose that we have here.
Okay. So once again, I'm always starting off just kind of fiddling with the nose, pushing up the tip, seeing what looks good. It looks like I've already, drawn out my safety margins here. And I've gone straight in for the perichondrial injection. So the injection onto the cartilage. Yeah. One thing I'm trying to avoid with male clients and noses is not giving them such a prominent tip.
Okay.
Because I find that is just so feminizing.
Yep.
So generally for men, I will still bring up the tip, make it fairly sharp, but I won't want it to lift up like the female case
patient.
Yeah. There was quite a prominent tip.
And again, you've got probably about 0.1, 0.15 mils of filler in that insulin syringe.
Yeah.
So you're not working with a lot.
Yeah.
And you're going straight into the tip first. You prefer working from the bottom up.
That's right. Yeah. And sometimes I will also do an injection underneath the base of the nose as well.
Here, yeah.
And I'll only do that injection if I feel like the base of the nose needs to lift up a bit. In this case, I felt like it was fine. And it's the same thing with males and females. Men, I don't think you should really push this base up too much. It starts to be feminizing.
Yeah. I mean, the amount he's got there, I think that looks fine. Look at how straight everything is in the bridge as well.
So how do you normally do noses? Do you like to do the perichondrial, so onto the cartilage, or more through the crus cartilage?
It's different every time for me, to be honest. And when we've got patients whose noses are really quite large, I find they're the most tricky. And I don't know what to do until I feel the anatomy.
Right.
But typically, I will do either. I'll go from above to try and project it up like this. But sometimes I will go like this as well in certain cases based on the anatomy.
Right.
I guess I would probably go from above more.
Okay.
I think that has more potential to give more projection, personally, in my personal view. Other people will disagree, and that's fine. People have different experiences. Yeah. One of the reasons I think it has potential to give more projection is because when I squeeze like this, and then I put the needle in, and I'm still squeezing so the filler can't travel left and right, but I'm putting that in. When I pull my syringe out, I will pull it out very quickly. And the reason for that is because it leaves behind a tract of negative pressure, and the filler will just track along that very, very slightly. Yeah. And when the filler tracks along that, it actually stands up a little bit, not a huge amount, but a little bit. And so you get a little bit more projection. Yeah. So for example, when I'm doing the chin, if I want more projection, I will put the needle in, specifically with quite a wide gauge, actually. And then I will squeeze from the side, so there's no movement over there. And then I will very quickly pull out, so it leaves a tract of air for a split second, and the filler comes up. And for the same amount of filler that I've put in, you might hear the zip moving along there. For the same amount of filler that I've put in, some is on the bone and some is actually creating a vertical column. Yeah. Without me actually creating a vertical column by releasing it in a column.
Yeah, I agree. That's a really good technique, as I do the same thing really. Yeah. And also, I'm not sure if you notice with a lot of trainees. Yeah. What they kind of naturally do is they'll go in very slowly and out very slowly.
Yeah, I know.
So that's one thing I explained to them. Coming out quickly, it creates that negative pressure. Yeah. Creates more projection for that same injection.
Absolutely.
But then also coming out quickly is actually more comfortable as well. Yeah. All the nerve endings are in the skin.
Yeah.
So the quicker you pass through that skin,
Yeah.
it's more comfortable for your patient as well.
Completely agree. I think for situations where I want it to stay deep down, so for example, on the cheek here, and I want it to stay, and I want a little bit, or even on the nose, I will put my needle down. I'll use this microphone. Hopefully it won't deafen anyone listening, but I will put my needle down. And then once I've released a little bolus of filler, my hand will actually squeeze the skin not deep down, but over the top. So there's pressure from above. So as I pull the needle out, it can't track up.
Right.
So I'm squeezing superficial layers, but not deep.
Okay.
So if there's any negative pressure, it's deeper. So it
Right.
stays deep
Okay.
than coming back up.
Right.
It's
So
not,
where would on the face would you use that technique?
so for example, chin.
Yeah.
If I'm coming in from the front, I'll do it quickly.
Yeah.
If I'm coming in from here and just resting the needle there, so the filler comes and projects this way.
Right.
If I pull it out slowly down, I don't want it to lengthen the chin.
Right.
So I'll put my needle in here, rest it on the bone, let the filler project forward, squeeze underneath
Yeah.
to put pressure that way, and then slowly pull the needle out, squeezing like that, and there's no tracts going down. And the reason I can say that works is because I've seen it under ultrasound. I've checked it, and it does what it says on the tin.
Right.
Again, I've never seen it taught anywhere. It's just something I figured out myself from using ultrasound. Again, one reason I always recommend ultrasound to people, you'll learn new things, you'll develop new techniques.
Yeah.
And so pulling out quickly can force the filler to track back. Squeezing before you pull the needle out and then stopping it coming back can keep it deep down as well.
Okay, right.
in
I'll
my
have to try that
experience,
one
yeah.
out. It's pretty good.
Give it a go. And I think ultrasound, I use which one do I use? I forgot the name of it.
Vino-P?
Vino-P,
Yeah,
that's the
that's
one,
it.
yeah. I'm not sponsored, but that is the one I use. Very reasonably priced and does the job.
Yeah.
It's really, really good. Let's have a look at the picture of this case, which is that one.
This one, yeah.
So from the front, I think the tip is a little bit, it looks smaller. In fact, even the width of the nose looks a bit smaller.
Yeah.
And
yeah.
I guess that's because you've done the nasolabial here.
Exactly.
Yeah.
Exactly. Yeah.
And that's a bit of a trick a lot of people don't know, I think.
Yeah.
If you treat this correctly, the pressure that this puts forward like that on either side of the nose just squeezes and
That's it. Yeah.
tightens
Yeah.
up the nose.
Narrows the nose. Yeah.
Yeah.
It's pretty cool. And then you will. It is quite subtle from the front, to be honest. But you
Yeah.
might also notice that the light reflex is more on the tip of the nose here as well. So
Yeah.
you've actually shortened the bridge there,
Yeah,
which is quite nice. And then apart from that, we've got a little bit of under eye work here,
yeah.
nasolabial line, and then you see a little bit of lip filler. Yeah,
I've just noticed,
So
yeah.
he was cool with it.
Yeah.
And
And
then
it doesn't
you
look
also
like he's
note-
had lip filler, really, apart from the redness, obviously.
that's
when
it,
that
yeah.
settles.
Nice and subtle, nothing feminine.
Yeah.
Still keeping those masculine ratios of the face.
Yeah.
And then the last thing you notice is the chin width. So before we've got chin that's about as wide as a nose. Now we're coming more towards mouth corner width.
Yeah.
So generally just more masculine features.
Yeah, absolutely. Let's have a look at the side view as well. Yeah.
So a little bit of
wow.
profile balancing here as well. So you've got
His
sharper.
upper lip is actually almost sort of caving in.
Yeah,
And now
exactly.
it's inverted again, just like you would expect.
That's it, yeah.
And the chin is much more in line. I think potentially he could have a little bit more in the lip, not in terms of the height increase, but the forward projection.
Yes, yeah, definitely.
agree.
Definitely.
The way I project it forward, are you being told off by your manager?
Manager's saying he actually did have some, and yes, he
Oh,
did. He did,
Okay,
yeah.
Interesting. Because it does look like he's come forward a bit.
Yeah.
But I think he's got a little bit more room if he's interested.
Yeah,
Not
yeah.
that he has to. But the way, I'll be interested to see how you do it. But if I want to increase the height of the lip, I'll put the filler relatively superficial, close to the surface, using whatever technique. If I want to try and project it forward, I will inject much deeper, closer to the teeth. And then that will almost mimic teeth and push the lip forward. Do you do it differently at all?
Yeah, so sometimes I do a bit of that. Sometimes I do a bit of tenting as well. Do you do tenting? Or,
Not
I know it's
massively.
controversial.
Not massively. I mean, tenting, for those that don't know, you've probably seen that in videos of Russian lips where they come from above and they do like 4 million injections going like this. And it's a tricky one. I mean, I think it can give a result immediately, but in a lot of cases, when they come back after a while, it just looks exactly the same.
Yeah, I mean, personally, I quite like it.
Yeah.
You know, from what I've heard, a lot of people, they do this technique and then they end up having a lot of migration later on.
I think that's not because of tenting.
Me too. I think it's because they're entering from the wrong point.
Yes, I agree.
know?
I agree.
Yeah.
If you where our moustaches are for me and Aaron, if you enter from there and then end up in the lip, and you pull the needle out, like we've just spoken about, filler tracking back, it's going to track out of the lip,
Yeah.
and you get a load of migration.
Yeah.
So I do sometimes do tenting, but I'll move the needle very slowly,
Yeah.
and I won't, because a lot of time you see tenting, they just go like super speed. I'm like, what are you doing?
Yeah.
Like, and there's barely any filler released in every point, and it's just swelling.
Yeah.
So I will try and do an actual proper vertical column,
Yeah.
and I will enter not outside of the lip, but within the actual red, the vermilion of the lip itself.
Yeah.
So there's nowhere to track out the lip. If it does track back, it's tracking back to still being in the lip.
That's it. That's it.
That's the only way I do it.
I think that's the key. Yeah, exactly. As soon as you come outside, you are making a new tract from inside the lip to outside the lip.
Exactly.
Then you get migration.
Yeah.
So it's just kind of a no-brainer to me as well.
You're building a bridge out of the place that you want it to stay in.
That's it. That's
And
it.
it's going to walk that bridge.
Exactly.
Yeah.
Exactly.
And what did you use technique-wise in this case for the lip?
So a little bit of linear threads, so
Okay.
fine threads along the vermilion border, the border of the lip.
Yeah.
And then a little bit of the body injection, which you talked about. So coming slightly deeper into the lip and then also leaving some threads of filler there.
Okay.
And then lastly, just a little bit of tenting. So within the vermilion border, but coming more as a vertical injection.
Yeah.
Basically just to build up the height of the lip slightly.
Yeah.
Fine. Yeah.
And it's very
And
similar to
I'm
what
the
I
same. I don't do super quick and loads and
Yeah.
it's more sort of a more controlled, slower vertical injection.
Yeah.
To really build the hype. And I think it's quite a powerful injection in my experience.
I think, I personally believe there's a difference between tenting, where you're going outside the lip and you're doing loads and loads and loads and loads,
Yeah.
versus slow controlled vertical columns within the lip.
Yeah.
And that second one, I don't class as tenting. I think it's just linear threads.
Pretty much. Yeah. It's a glorified linear thread.
Exactly,
Yeah.
but in a different orientation.
Yeah.
So you've got different techniques of placing fillers. You've got a bolus, where you just put the needle somewhere, you release the filler and a ball comes. Whether it's a big one or a small one, it's a bolus. Then you got things like threads, where you start to press the plunger and you move the needle back, so you leave a line of filler. And linear threads are very much used in lips. And what we're now talking about is typically a lot of people will do horizontal threads, horizontal linear threads. Absolutely fine, no problem at all. Tenting, which is coming from here lots and lots of times. But then I'm saying there's a difference between tenting and linear threads within the lip itself, which are vertical, which I think is much, much better, in my personal view anyway.
Yeah.
Not a traditional tenting in that style. Not a fan, personally.
Yeah.
So
I haven't shown a video of lip filler because I just find it's too bloody. It's a bloodbath. So I haven't given you one of those.
So let's talk about that. Let's talk about that, because that must mean typically you prefer a needle for lips.
Exactly. So do you use cannula for you?
I mean, I use both. For something really, really specific in one point, I'm happy to use a needle.
Right.
But for overall even volumization, I will actually stick to a cannula.
Okay.
Because just like you said in the temple, it's easier to spread it over a wider area. Yeah. What I will do is I will enter my cannula not outside the lip like a lot of people do. Because again, if you enter a cannula here and then you end up in the lip and you do lots of threads and pull back, it's going to migrate back to here. And you get migration out. Right. So I will enter my cannula on the actual vermilion itself.
Okay.
So even if the filler tracks towards the entry, it's still staying in the lip. Like it's not going to go anywhere else.
Right,
so there's no migration risk. So I will enter in each corner like this, and then just spread, again, like teardrop filler, keep the cannula moving, really slow trickle of filler as it slowly comes out. So I'll just keep the cannula moving and a very, very gentle pressure on the plunger. So only a slight trickle comes out and just keep it moving. And at the end, again, I never have to massage.
Right.
It is so smooth the entire time.
That's interesting.
Where it goes wrong is you're too aggressive doing that.
Yeah.
And you can't tell whether it's filler or swelling.
Okay.
So you've got to be gentle.
Right. Yeah. I mean, Personally, I haven't tried using cannula.
Okay.
Just because I've always assumed that the needle kind of gives you more of a sharp result,
Yeah.
like coming along the vermilion border.
Yeah.
But no, I've heard of people using cannulas. So you're seeing yourself,
Yeah.
you used it. So I might just have to come and watch you do one.
Yeah, I
sometime.
mean, but I would say probably the vast majority of my cases are cannula, simply because the vast majority of my cases are not one individual tiny thing about a lip in one place.
Right.
If I had that, I'll almost always go for a needle.
Okay.
And I think that's for a reason. But I agree with you that the needle is going to be sharper
Yeah.
for places where you want sharpness, like the border.
Yeah.
But even then, if I'm using a needle, my needle will not necessarily be in the border itself. It's just inside.
That's right. Yeah.
If it's just on the border or just outside, it could migrate out again.
Exactly. Yeah. And that's what I tell trainees as well. Don't go on the border. You want to go about a millimeter below
Yeah.
it, and you'll still get a brilliant result without the migration.
100%. And which filler do you prefer to use for the lip normally, or which couple of fillers?
So lips are one place I actually do use Juvederm sometimes. So sometimes I use about like a Juvederm Ultra Smile.
Okay.
Or I'll use an Intraline M2.
Okay.
So I'm going for more soft fillers.
Okay.
I used to use like a medium filler, but then I find actually it tends to make the lips look a little bit rubbery. So prefer like the twos, like the softer side. What about you?
And I hate Juvederm.
Okay.
As many people on this channel know, I would stick to something really soft, something like Reveness Kiss.
Okay.
Or a little bit more, I'll go for Reveness Ultra. A little bit more, I'll go for Reveness Outline.
Okay.
And I think that rubbery look is from not just the volume that's injected, but what's injected as well. I think both play a role.
Yeah.
It's also to do with how hydrophilic a filler is, how much water it draws in. And if it draws a lot, it's going to look fat and expanded, unfortunately.
Yeah.
And I've never had that with Reveness, actually,
Fair enough. Yeah.
Not purely because of the filler. I think I'm not overfilling
Technique as well. Yeah.
But I think at the same time, if you go to a great injector, even with a terrible filler, you'll probably get a great result.
That's it. Yeah.
As to whether there's a biological reaction, that's not to do with the injector. That's to do with the chemistry of what's in the syringe. But in terms of the actual result and the filled result, I think even with as the injector, like I said, the injector is more important than anything else.
Yeah.
So I think, did we look at before? Yes, we have. Let's have a look at, I think, this one, which is the last one. Oh no, we've got that one as well, haven't we?
Yeah.
So let's have a look at, no, that's the last one.
Is that the last one?
Yeah.
Yeah.
So a female patient coming in for temples.
Yeah. So in this case, it was So she had basically temple hollowing, which from one aspect, she had very good cheekbones, but just superior, very hollow.
Yeah.
And interestingly, she actually wanted more cheek filler. So it's kind of back to that same conversation I had to have that, if we add more width, it's going to make the temples more hollow and make it more aged. So together we agreed, let's restore some of that volume in the temples.
And what's the line? I paused the video. What's the line you're drawing there?
Right. So this one is just pretty much a line from the tragus to the lateral canthus of the eye.
Yeah.
And along that line pretty much goes along the zygomatic bone.
Cheekbone, yeah.
Yeah. And pretty much I'll just go halfway across and it just make a small pilot hole there. It's a very safe area, very avascular. You've got the superficial...
so pilot hole means the entry point for the cannula. So those that don't know.
Yeah. It's a very safe area because we've got the superficial temporal artery sitting all the way back here near the tragus. So we're far away from any kind of main vessels. I'm also just drawing out the temporal fusion line as well. And that's pretty much an area that we don't want to go above, just because it starts to get very tight there and it just wouldn't look right, to be honest. So I'm focusing most of my volume within these borders.
So that line where the video is paused, you're drawing that because you don't want to put filler beyond that and go into forehead territory.
That's it, yeah.
And you're drawing the cheekbone or the eye socket there.
That's right, yeah.
And then the edge of where you're going to fill.
That's it.
So you've got a sort of wedge-shaped area.
That's right.
And as you pilot hole, the entry for the cannula.
I wonder, will I use local anesthetic? No, I won't.
And then the
Let's see.
cannula in there.
Okay. So one other thing I'm just doing here, you see I'm just keeping it at the entry point.
Yeah.
I'm actually just injecting a small bolus of filler just in that point.
For the anesthetic.
That's right, yeah. So the filler has some anesthetic in it. It just anesthetizes the entry point, and then it makes it just much more comfortable for me to start gliding the cannula back and forth into the area. So doing a little bit of subcision here. I'm opening up the potential space in the superficial fat compartment.
So you're not actually releasing filler.
No.
You're trying to create a pocket of space.
Exactly.
So the filler can sit and spread across that pocket.
That's right.
And you can see your hand is, none of your fingers are actually on the plunger.
Exactly.
Just on the edge of the video there.
That's right.
So you're still just trying to make some space.
And you can see that there's resistance there in certain points. It's just the cannula kind of moving and sort of subcising the fascia, opening
separating
it
the layers.
Yeah.
And now I think you're possibly injecting a little bit. Yeah.
Now we're starting to inject.
So it's almost like a fanning motion as you pull back in each different angle.
That's right, yeah.
Left and right. And you're just trying to keep it between the white lines that you've drawn for safety. So you can just, the tip of the cannula, you can see a bit of a vein.
Yeah.
Which will be a little bit deeper. So you're okay going superficial.
Yeah. Starts to look a bit violent here, but don't worry, it's not.
Patient's not really going to feel anything. It's absolutely fine. Because by this point, there's quite a lot of filler there. So there's also quite a lot of anesthetic there.
Yeah.
So it's very, very, very comfortable the further along you go.
Exactly. And I'm also stretching from top and bottom as well. So the more I'm tauting the tissue, it's also making it more comfortable as well.
So you've gone down to about 0.6 of a mil used.
That's right, yeah. And I'm doing a little bit of the technique you were talking about as well. So I am actually
massaging,
giving a little bit of a squeeze while it's injecting too.
Yeah. So that's probably total so far about 0.7.
Yeah, roughly.
For one side. And now, so this is probably a 2 syringe case.
Yeah, 1 mil per side, yeah.
And you will have drawn the same safety markers on this side.
Yeah.
And opened up the space in the same way. Why did you choose to enter there and not closer to the hairline?
So you mean from up here?
From here. So where the entry of the cannula, where the cannula has gone into the skin.
Right.
Is that just your preferred entry point for fanning filler there?
I see. I like going just where the cheekbone is.
Okay.
This, it never kind of bleeds much. It's not very vascular. Occasionally I have gone slightly higher.
Yeah.
And it's just nicked the vessel.
Okay.
And big hematoma.
Yeah.
So that's why I tend to keep it a little bit lower, just along the bone.
Okay.
What about you? How do you approach this?
Different every time, again, to be honest. Sometimes I will go a little bit more posterior, a little bit closer to the hairline. Sometimes I'll go there. I base it on where are the vessels for that individual patient.
Right.
And I'll just avoid where the vessels are.
Okay, so you got ultrasound first.
Yeah.
Potentially.
Or to be fair, sometimes you don't even need that because you can see the vessels.
Right,
because they're so sort of shallow, right? Yeah. So I'll just try and find where the vessels aren't and then go from there. And that's all I need to do.
Right.
So there you've probably used about half the syringe so far.
Yeah, roughly half there, yeah.
And I think in temples, very, very common to have a difference in volume per side of like 0.2, 0.3 if we're treating in this layer.
Definitely, yeah. Typically the side they sleep on has needs the more. It requires more.
And I think actually once you make the temples look even, sometimes the cheeks, if there's any asymmetry in the cheekbone projection, shows up a little bit more.
Oh yeah, for sure. So this, this will actually reduce cheekbone contour actually.
Blends it in more.
Yeah. But it can be a step in the right direction for your client.
100%. Do you want cheek contour or do you want to look younger?
Exactly, yeah. One also quite interesting thing I've noticed is when you restore the volume in the temples, the lower face starts to look more fuller as well. Okay. Because once you've with slightly older clients, when they've got quite a gaunt cheekbone, they will look hollow above and below.
Yeah.
So restoring that part above also helps with that lower part, sort of like that sort of like the mid cheek groove.
Picking it up.
Yeah.
Yeah, absolutely. Let's have a look at the before and after on this. Which one? Is it that one?
That's one, yeah.
Okay. Wow, what a difference.
So quite
Subtle. And I think most people wouldn't look at that area unless they knew it had been filled like we have
Yes.
at the minute.
Yeah.
And I think in the before, the cheekbone projection actually is fine. I don't think there's anything wrong with that at all.
Exactly.
I think she looks good. And potentially over time, I think she could have a little bit more temple filler.
Yeah, definitely.
And just smooth that transition from cheekbone into the side of head a little bit more, because it's still a little bit scooped and you want it more, not bulging, but a little bit straighter, I think, than it is already.
That's it.
So how many mil was that roughly?
So temples are 2 mils in total.
Yeah.
And then I'm just seeing what other work I've done. So I've done a little bit of work in the nasolabial lines.
Yeah.
And also you might notice that the jowl is reduced as well.
Okay.
So this looks like 1, 2, 3, probably about 4 or 5 mils here.
4 or 5 mils. And what kind of cost are we looking at for something like this?
4 or 5 mils. What are we looking at here for this? Yeah, so max 1,600.
1,600. Okay, cool. And again, talk us through which fillers you use in this. I think that was Intraline, I'm guessing, for pretty much all of it.
So we've got Intraline M3 for the temples, and then we've got Intraline M4 for around the chin.
Yeah.
And then for the nasolabial lines, typically I use M4 and M3 together.
Okay, so M4 deeper.
That's it.
M3.
M4 deep, so to project the piriform fossa up, and then just a minimal amount of the M3 superficially in that fat compartment, just to reduce the line a bit further.
Okay. Incredible. So I think that's going to last a long time.
Yeah, for
You're
sure.
talking several years, and she only needs a minor top up in certain areas.
That's it.
What I see is, I mean, has she had lip filler in the past, do you think? If you remember?
I'm just trying to remember. Did I do lip filler here? No, I don't think I did. No, possibly. I'm not sure.
I've seen patients with good lip volume like this still want more.
Right.
I think that's when you said earlier, it's not just about knowing when to inject, but when to not inject.
Yes.
I would say no to her if she wanted lip filler.
Likewise. Yeah.
Yeah.
Me
she
too.
doesn't need it.
What would you do anything else here?
In terms of injectables, I would plan a little bit more temple filler, but not much.
Yeah.
I think 1 syringe across both sides is probably going to be enough.
Yeah.
And then I would probably look in this region here, upper eyelid, maybe a little bit hollow.
Upper eyelid filler, yeah.
But just on the medial side, so the inner side about there where my thumb is.
Yeah.
Just to give that a little bit of volume.
That's one area I didn't look at.
Yeah.
Yeah. I see that now, yeah.
And then I would probably do a load of Sunacos there and under the eye to help that texture as well. And then in terms of the piriform fossa, so right here, potentially a little bit of room for a little bit more over time, but you've got to be careful to not make everything else look puffy.
Exactly, yeah.
And then after that, I don't think I will do anything in the lower face. I think it's all fine. She's got a little bit more projection on the photos right of her jawline than the photos left in the after.
Yeah.
And I think possibly one clenching muscle is a little bit bigger than the other. I would analyze that, get her to clench and feel, does one feel much thicker and stronger than the other? If so, I potentially would add a little bit of Botox to the thicker side to make it more even.
Yeah.
But that's being picky and pedantic, to be honest. A little bit of inflammation in the skin in certain areas, I think, around the mouth especially.
Yeah.
I would probably look to certain skincare LED to calm that inflammation down. And then apart from that, what would I have said? Apart from that, there's quite a few things I've listed there, but that's the gist of what I would do, subject to obviously her thoughts and wishes as well.
Yeah.
What about you? Anything different you'd do?
Yeah, I mean, pretty much I would just, from here, just kind of maintenance things like, a bit of Botox 2 to 3 times a year.
Yeah.
Tidy up the skincare routine.
Yeah.
But although it looks like she's pretty much doing all the things she needs to do, skin quality, I would say overall pretty good.
Fine.
It looks like she's recently had some Botox. Forehead looks nice and fresh. That's
Cool.
about it, really.
And I think that's all the ones that we've got here today.
Nice.
If people would like to get in touch with you for some treatment, what's the best way?
Yeah, so you can visit my website.
Yeah.
It's www.karwalaesthetics.com. You can also see more of my content on my Instagram, so Karwal Aesthetics.
Yeah.
And we are just in the process of making a YouTube channel as well.
Nice. Okay, well, this is going to be a bit of a boost for you.
Exactly, yeah.
So my conversation worked then.
It did.
Brilliant. Well, Aaron, thank you very much for coming down.
Thank you so much.
If any of you want to get in touch with Aaron, I'll leave some links to it in the description below. If you've got questions about some of the things you've seen, obviously we haven't discussed every single thing about every single case. We don't want this to go on for 10 hours. But if you liked this kind of style of episode, let me know. We'll try and do some more things like this as well, so you can see what goes through a doctor's mind before we actually act on a patient. Other than that, thank you very much for watching, and we'll see you next time.